Good morning. Good to see everybody here, members of the commission and of the public. Dr. Galley is expected later, I believe, but Elizabeth has asked me to chair the meeting until Dr. Galley arrives. So welcome. This is a call to order and we will do the roll call, I believe.
Good morning. Secretary Dr. Mark Galley, Dr. David Carlisle, Dr. Sandra Hernandez, Richard Kroenig,
Here.
Ian Lewis,
Present.
Elizabeth Mitchell, present, Dr. Richard Pan,
Present.
Don Moltz.
There is a quorum, and our next item is executive updates from Director Landsberg and Deputy Director Pagano.
Thanks very much, Rick. Good morning, everyone. Secretary Galley is currently testifying before our Joint Assembly Health and Housing Committee on the Behavioral Health Modernization Proposal, and will be with us as soon as the legislature releases him. And Dr. Hernandez is not able to be with us this morning. We have a slide up showing our agenda for today. So Vishal and I do have a few updates we'll give you. Our only action item today is to approve our June minutes. And then we have three very substantive informational items. We're very pleased to have Sheila Tatayan return to give an overview of our cost and market impact review, or CMIR regulations. So the team did release those regulations on July 31st, had workshopping. So looking forward to that presentation and your thoughts and questions about the approach that we've proposed on cost and market impact reviews. We then will come back to our favorite topic of THCE, the total healthcare expenditure measurement, and look forward to Michael Baylett and Vishal walking us through some items there. And then folks had asked for an overview and a display of our all-payer claims database. So we're very thrilled to have released our first reports of the HPD, California's Healthcare Payments Data Program, the last week of June. We had a July 1st deadline and we met it. So we'll be pleased to have Mike Valley and some folks on his team present some of HPD data, and we can talk a little bit about how we can use that for OCA. So that is our agenda this morning. So I'd like to provide some HCI department updates, and really one major update this morning talking about the distressed hospital loan program, which was included in this year's budget in response to the closure of Madera Hospital and the financial distress that other hospitals are facing. So the distressed hospital loan program is a collaboration between HCI and the California Health Facilities Financing Authority, or CHFA. It offers interest-free working capital loans to nonprofit and publicly operated financially distressed hospitals that are facing a risk of closure while they implement turnaround strategies to regain financial viability. So there's $300 million available in the program. That was adopted through the state budget. Part of it will be coming through the forthcoming MCO tax. So July 31st was the deadline for completed applications from hospitals. We have reviewed those applications to assess financial distress, looking at both liquidity and operating margins, also looking at community need and hospitals' proposed turnaround plans for regaining financial viability. We received 30 applications for the program, have reviewed those, and we look forward to announcing awards in the coming days. We're certainly learning more about the financial challenges some nonprofit and public hospitals face, and hope the loan proceeds can help them get back on their feet. And just in working on this program, I mean, I think we all know this, but Jeff definitely has highlighted for us the perverse incentives hospitals have when they're paid fee for service. So we've seen the decision some hospitals have felt forced to make to offer lines of business that are money makers versus some critical lines of business that may be harder to make money, but may be very important for the community. So really points to the need for value-based payment and reliable revenue for small vulnerable hospitals, and just points to the importance of the work we're doing on value and focusing on value-based payments. Then we have one additional slide wanting to make sure that we're tracking some of the important reports and data that are coming out. So in June, you all may have seen that the Centers for Medicare and Medicaid Services Office of the Actuary released projections of national health expenditures for 2022 through 2031. And it is not a pretty picture. CMS projects that over this time period, the average annual growth in national health expenditures will be 5.4%, outpacing the average 4.6% annual growth in gross domestic product. This growth in national health expenditures would result in an increase in the health spending share of GDP from 18.3% to 19.6% in 2031. So CMS highlights the trends for the three largest spending categories: hospital, physician, and clinical services, and then lastly, retail prescription drugs. So you can see the percentages for each, that hospital spending is expected to grow fastest, averaging 5.8% for 2022 to 2031, followed by spending for physician and clinical services, projected at an average of 5.3%, and then spending for prescription drugs estimated to be an average growth of 4.6%. So obviously we recognize that this is not national data, it's national data. It is national data, not state level data. CMS last published state-specific health expenditure updates last August, but these national increases underscore the important work ahead for OCA and this board as we try to slow the rate of growth in healthcare spending. So those were the couple of updates that I wanted to give. And with that, happy to turn it over to Vishal Pagani.
Thank you, Director Landsberg. So as we do at every meeting, I'd like to remind the board about our slide formatting key. As you know, the statute denotes different roles for the board in different areas. We use a yellow board in the presentation, yellow arrow in the presentation for areas over which OCA has decision-making authority. It's important to get stakeholder input on these areas, and these meetings are an important way to engage with both the board and members of the public. For areas where the board has ultimate decision-making authority, we note it with a green arrow. Now I'll turn it back over to the chair.
Thank you for the updates. We now invite public comment related to the executive updates provided by Director Landsberg and Deputy Director Pagani.
Or any questions from the board or
questions
comments.
from the board.
Thanks.
Certainly. Richard.
Thank you, and thank you, Director Landsberg, for your presentation. Just perhaps a brief question about on the national health expenditure. Was in the paper, did they talk about, as they're looking at that, the year span, how much of that is perhaps driven by the aging population in the United States, right? So we know that when we looked at aging in California, when I was in the legislature, we're looking at long-term care spending and long-term support and services. We anticipated, just because of aging alone, we'd see a 5% increase per year, just driven by demographics alone, aside from anything else. So I was wondering whether you could comment on that.
Yeah, I mean, they certainly do look at demographic changes in population. I don't know if they actually calculated the extent to which, what percentage of the expected increases are related to that. I don't know if Vishal does.
They did account for that. They said the tail end of that period, it's a 9-year period ending in 2031. So they said that's when the last of the baby boomers are getting into Medicare. So some of the spending increases in Medicare or spending growth in Medicare are related to that. And then also the Inflation Reduction Act, some of the benefit design changes related to the $2,000 kind of cap on drug spending, that would shift the cost to the government. So that there's some spending increases for that. And then it's offset by some of the negotiation that they could do to save money on drugs through the IRA. Yeah.
I would think also that
Mike, Don.
that's gonna affect utilization, but I would think that price is an independent consideration, and I mean it adds to spending certainly, but that is one way of looking at the extent to which the demographic factor or piece contributes and doesn't contribute.
Yeah, Dr. Penn, I don't think there was anything in this article about that, although I did not read it as carefully as I might have. But certainly, as Vishal said, OACT has done a lot of work on this over the years, and the aging effect is pretty small. I mean, maybe 0.2% a year, so not zero. But the fact that I and my cohort are getting older contributes to increase in health spending, but it's a pretty small effect. I mean, I guess small is in the eye of the beholder to the extent that we're comparing 5.4% increase in health spending to 4.6% increase in GDP. That's a 0.8% difference. And if 0.2% is coming from aging, that's a quarter of the difference. So.
Yes, thank you. And I thought that this was a really great, very interesting slide also. I've not read the article, can't wait to read it. But one of the headliners there was the maybe breakaway of pharmaceutical price increases that, I don't know, my impression is that historically they've kind of led the pack most years. But otherwise, this seems to be part of the hopefully not inexorable trajectory of healthcare increases. Going above 20%, of course, will be a very significant moment when that does occur.
I think OACT is assuming that the negotiation authorized by the IRA will have a significant effect on price increases for pharmaceuticals. So I hope they're right. Elizabeth.
Just to add on, as we go forward, really trying to also tease out the impact on the commercial sector versus public purchasers, because our members are seeing, double-digit up to 25% increases right now that clearly aren't driven by aging. It's really about pricing and market consolidation. So really understanding that will be great.
If there's nothing else from my colleagues, I now turn to the public for comment on any of the items that you've heard so far.
We will now recognize members of the public for comment on agenda item 2. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. I note for the record, we have roughly 100 people attending virtually. Those in this room may line up at the podium. Those attending virtually who want to comment should click the raise hand button. Those dialing in can press *5 to raise your hand. It will track the order in which your hands were raised. During the public comment period, you will be promoted to presenter and unmuted. You will need to unmute on your end. We also invite you to provide written comment at oca.hki.ca.gov. Please note that while the Healthcare Affordability Board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. I will start with the individual at the podium. Please go ahead.
Beth Capel on behalf of Health Access California. To add to this important discussion, it is our hope that in future there will be a comparison with not only the gross domestic product, but also median wages or median income, the ability of consumers to afford health care. In addition, for those of us who have dealt with the state budget, including the long-term care aspects of it, both nursing home and in-home supportive services, it tends to loom very large. But that is because those costs fall on the Medi-Cal program where the state has such a large share. Whereas looking at national health expenditures, apparently it's a smaller fraction than we are accustomed to in our state budget deliberations. Thank you. And almost non-existent in commercial insurance, of course.
Looking to the virtual room, seeing no hands raised. We now have a hand raised. Stephen McDougall, please go ahead. You need to unmute on your end.
Thank you. I'm Steve McDougall from the California Federation of Teachers, based in Monterey County as home. I know the board is no stranger to Monterey County reporting out in these meetings, but I just want to say, I wish our annual increases were the amounts that were reviewed earlier. I wish they were at that amount. We're in an area where some procedures are charged 800% above Medicare reimbursement rate. Monterey County is in desperate need of intervention. I don't know if you can help us, but I thought I would point that out. Thank you.
Thank you. Looking back to the room, seeing no members of the public stepping up to the podium, looking in our virtual room, seeing no hands raised. That concludes public comment on this item.
Thank you. We will now consider action consent items, and I'll hand this over to Deputy Director Pagan.
We just have the June meeting minutes. The minutes have been distributed and include written public comments that we've received since the June meeting.
Can I get a motion to approve?
I will, in second.
We now invite public comment again.
Looking to the room, inviting members of the public to step to the podium. Please go ahead.
Of healthcare. Oh, thank you. So we cite a study or more to showing the opposite. And then secondly, we did find that the presentation narrowly focused on issues related to hospitals, physician organizations, and missed some important developments in the healthcare industry, including related to health insurer consolidation and the vertical integration of health insurers with pharmacy benefit managers, physician organizations, and so forth, where providers are stuck in a situation where single entities can control many critical inputs to the healthcare delivery. So we just ask that these alternative perspectives also be aired. Next, just want to move quickly to the spending target discussion. We really do appreciate the conversations about the various adjustments that the office is considering to the spending target adjustments, really believing these are critical to account for costs that are beyond healthcare entities' control. Do remain concerned, though, at the aversion to clinical risk adjustment with the potential equity impacts of providers facing an incentive to avoid treating some of the highest need, most vulnerable residents in the state. I would just quickly note that this equity as relates to risk adjustment was a major topic of conversation at the recent investment and payment workgroup meeting with many stakeholders expressing significant concerns. So with that, I'll close my comments, but thank you for offering the opportunity.
Looking to the virtual room for public comment. As a reminder, please raise your hand and you will be unmuted. If you are dialing in, please press *5. Seeing no virtual hands raised at this time and seeing no members of the public at the podium in the room, that concludes public comment.
The motion is to approve the minutes. Is there any additional discussion from the board? We are ready to vote.
Secretary Dr. Mark Galley, Dr. David Carlisle,
Aye.
Dr. Sandra Hernandez, Richard Kroenig,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell, aye. Dr. Richard Pan.
Aye.
So the minutes are approved. We will now move to item 4, information items, and I will turn it over to Deputy Director Pagan. Vishal.
Thank you, Chair. For this agenda item, I'd like to turn it over to CJ Howard, Assistant Deputy Director for Healthcare Spending Targets, to discuss the June Advisory Committee member feedback related to the Cost and Market Impact Review program.
And I should have included in my executive updates that we did convene the advisory committee for the first time, and I'm pleased that CJ Howard will be talking about some of the input that we received from the advisory committee in this very room. We had a great first meeting.
All right, good morning. My name is CJ Howard. I'm the Assistant Deputy Director over the Healthcare Spending Targets branch. We'll just start with a brief overview of the process by which OCA will use to present feedback to the board from the advisory committee. And then I will dive in briefly into some of the feedback that we heard related to CMIR. And as you'll see later in the presentations today, we'll touch on feedback that we heard from the advisory committee related to total healthcare expenditures and total healthcare expenditures measurement. So OCA staff and board members who attended the advisory committee will provide the board with a summary of the issues and topics that were addressed in the advisory committee hearing at the subsequent board meeting. OCA staff will aim to integrate advisory committee discussions, deliberations, feedback into the relevant agenda items. So for example, today we have an agenda item related to CMIR. I'll address briefly the CMIR feedback that we heard. Later, Deputy Director Pagani will talk about the feedback that we heard related to THC and so forth. And OCA staff will attempt to present the board with as many viewpoints from the advisory committee as possible. Just want to note that there's, generally speaking, we don't strive for consensus. We really want to use it as a information gathering and sessions and where we hear multiple points of view. And so we'll, to the extent possible, present to you how much support we might have heard for any particular theme or element or piece of feedback. Or if the advisory committee did reach consensus through discussions, we would try to report that back to you as well. OCA encourages the board members who attended the advisory committee to bring forth any additional elements and themes from the advisory committee's discussions that OCA staff may have missed in our presentation back to you. So in this case, Ian Lewis attended the June board meeting. As we're going through my brief remarks, we'll ask Ian to also chime in if there's anything additional that he'd like to add to highlight from the advisory committee deliberations and discussions. All right, so the advisory committee member feedback related to CMIR. This is a summary of the feedback and input that from the advisory committee related to cost and market impact review. There will be, Sheila Tatayan is going to address more feedback that we heard and integrate some of the elements we may have addressed here in more depth and detail also, but feel free to invite any questions as we go through. But only got 2 slides related to the CMIR feedback. So the biggest issues that we heard was that OCA should account for situations in which an acquiring entity engages in serial acquisitions within the healthcare sector and or geographic region where a single transaction may fall below $1 threshold, but the cumulative impact of the serial transaction significantly impacts the market. Additionally, the advisory committee noted that OCA should conduct market consolidation analyses such as cross-market mergers or vertical integrations beyond a geographic market demarcation that do not fall under the jurisdiction of the Attorney General or the Federal Trade Commission. Next slide. OCA should promulgate regulations that reflect OCA's authority to identify and review potential market failures and address trends not captured within existing regulatory structures. OCA should consider quality, appropriate use of care, overall delivery of care, and source of community care when evaluating market impact in addition to cost. And lastly, OCA should consider Medicare, shared savings program, and accountable care organizations in which competitor organizations band together. In other words, Medicare product lines could become monopolistic. And now lastly, a committee member also cautioned that CMIR public noticing has the potential to exacerbate or unlevel the playing field For example, unregulated private equity or publicly traded companies can view notice transactions and increase bidding. Board Member Lewis, did you have anything that you'd want to add to that?
No, just a high-level comment about the group. It was a very substantive conversation and got, deep into the same technical weeds that we have been, and it was very interesting to listen into, and encourage you all to sign up for the next ones. I don't have anything particular on the advisory committee with CMIR.
Thank you. Did you also look at the impact on California purchasers of California entities acquiring others outside of California, like Kaiser acquiring Geisinger, and its impact on California ratepayers?
I'm gonna look to Sheila to help fill in some of this.
Sure.
If you could hold that question, I'll be stepping up to do a whole presentation of the regulations.
Thank you.
Great. I think with that, then, this is a perfect time to turn it over to Sheila.
All right. I'm trying the movable mic today. I'm used to moving when I speak. So, and we'll see if my remote works for slide advancing. So, as I said, I would be going over an overview of the regulations for you. This is going to provide you with a briefing of what we've done in terms of taking the statute and turning the statute into implementing regulations to clarify and make specific the statute, which is the role of regulations. I want to note at the outset that OCA has emergency regulation authority. The legislature granted OCA emergency authority. And so what we heard during the drafting of the legislation was a concern that with emergency regulations, there would not be sufficient time for public comment. But as you can tell, and as we had promised during that time of the legislation, we said we would give ample time for public comments. So we posted these regulations to our website on July 31st, and we will continue to take comment until August 31st. We held a workshop on August 15th, which was very well attended, and I will provide information about that workshop. And then we intend to submit the emergency regulations to the Office of Administrative Law in October. So there will be other opportunities for public comment as well. So even though they are emergency regulations, I just want to note that there's ample time for the public to comment, and we have already received comment. So today I'm going to be going over, as I said, the statute to the implementing regulations. And so we'll start with the material change notice filing requirements, who must file, and we've developed some thresholds. So do the healthcare entities meet the thresholds? And then we've also looked at the types of transactions. So once you determine whether the threshold is met, it's a situation of looking at whether your transaction circumstances warrant a filing. We've defined healthcare services for purposes of the regulation, and we've also outlined when the healthcare entities need to file their material change notices. And then I'll go over what's required in the material change notice, which is very specific information. And then I'll go over the timeline. What happens after the material change notice is filed? What is OCA's process? And then I'll explain OCA's decision at that point, after they've reviewed the material change notice, whether to issue a waiver or to conduct a full cost and market impact review. We call this part of our program Assessing Market Consolidation. We abbreviate it to CMIR for shorthand, but by no means will every transaction go to a full cost and market impact review. I'll go over the factors that OCA will use to decide whether to conduct the CMIR, as well as the factors that will be considered when conducting the CMIR. And then finally, I'll go over timeline, and you'll have a nice visual of what the timeline will be. And once I'm done explaining the regulations, I will then go on to the comments that we received at the public workshop. And then finally, I'll be happy to take all of your questions at the end, because I think you'll see that some of the comments that we received at the public workshop maybe some of your questions that you have today as well. All right, so the question is who? Who has to file? So OCA's jurisdiction is over healthcare entities, which the statute defines as payers, providers, or fully integrated delivery systems. And so for purposes of regulation, we have further clarified that definition. And I want to just call out that the statute does talk about pharmacy benefit managers, and the regulation makes clear that pharmacy benefit managers are defined as a payer in the statute. The proposed regulations also include management service organizations, MSOs, as healthcare entities. And then we do recognize that in many of these transactions, it may not be the healthcare entity traditionally as we think of them, but it could be a related entity that controls or is controlled by the healthcare entity. So the regulation makes clear that a healthcare entity includes affiliate subsidiaries or entities that control or govern the healthcare entity in the transaction or are controlled by the healthcare entity. So then we get the full gamut of the potential corporate entities and affiliates that could be involved in the transaction. All right, the statute allows OCA to establish regulations that will set the thresholds and circumstances that really warrant a material change notice. So we've done that in the regulation, and the proposed transactions, we've set some monetary thresholds. So in determining whether you need to file a notice of your transaction, you first look at these monetary thresholds. So the first, let me go back. I think my slide advanced a little bit further. Here we go. The first is, what is the healthcare revenue? What's the annual revenue of the healthcare entity? If the healthcare entity has at least 25 million in revenue or owns or controls 25 million, then it meets the threshold. We recognize that some entities may not have revenue of 25 million, but they may control assets of at least 25 million. And so if you have 25 million and you're entering into a transaction with any other entity, you meet that first bullet or that first test. The second one, which is an or, so if you don't meet the first one, go on to the second one. You know, I think I'll pause after these thresholds for questions because these were, a lot of thought went into these, and there may be some specific questions about these monetary thresholds. So then the second one is, if the healthcare entity has 10 million in revenue or owns or controls 10 million or more in revenue, and is entering into a transaction with another entity that has 25 million. So that's the second one. So you're either 1 or 2. And then the third one is, are you a healthcare entity located in a health professional shortage area, HPSA, or serving at least 50% of patients residing in a health professional shortage area? So this is the first step. Do you fit into any of these thresholds? And I'll pause for questions right here because it looks like you might have one.
There we go. Can you say a little bit more about what constitutes a transaction? I mean, it seems to me that transactions, I mean, potentially they run the gamut, some of which are things that we should be looking at, and some of which, you know, I mean, it could include purchasing an IT system or a building lease or so what are the parameters?
So that's a very good question. The regulation defines transaction. I don't have a slide for that, but I will read you the definition. And then as I move on to the next slide, that is the second part. First, do you meet any of these thresholds? Then there are 9 circumstances we've laid out for the transaction. So if your transaction meets any of those 9 circumstances, it meets the parameters of a transaction that OCA would review. But first, let me just go to the definition of transaction. A transaction includes mergers, acquisitions, affiliations, or other agreements involving the provision of healthcare services in California that involve a change of assets, sell, transfer, lease, exchange, option, encumber, convey, or dispose, or entail a change directly or indirectly to ownership, operations, or governance structure involving any healthcare entity. So that is the broad definition of transaction in the proposed regulations. So this is a very broad definition. Now, when you're trying to determine whether you have to file, you first look at these three parameters, which are the monetary thresholds and the geographic threshold relating to underserved areas. And if you meet any one of those, then OCA expects that the healthcare entity will look at these circumstances of your transaction. So we've laid out in the proposed regulation 9 circumstances that would trigger the filing requirement. Okay. So the first is the fair market value of the transaction 25 million or more, and does it involve provision of healthcare services? Later, I'll get to how the regulation specifically defines healthcare services. Okay? And these are any one of these. If you meet any one of these, it triggers the filing requirements. Number 2, is the transaction likely to increase annual revenue of any healthcare entity that's a party to the transaction by at least 10 million or 20% of annual revenue, and that's at normal operations. 3, does the transaction involve the sale, transfer, lease, exchange, option, encumbrance, or disposition of 20% or more of assets of any healthcare entity that's a party to the transaction? So if this happens to any of the healthcare entities as a result of the transaction, it triggers the filing requirement. And number 4 relates to change in control, and that is, does the transaction involve the transfer or change of control, responsibility, or governance of the submitting healthcare entity? So that is specific to the submitting healthcare entity. Yes.
Actually, this, sorry to, but you.
I can go back to the next.
Yeah, I want, actually, just, can you go back to the first one, who must file notice of material change?
Sure.
Because I didn't know we were taking questions along the way. No, the next one, yeah.
There's a little bit delay here.
So I'm trying to clarify that the last one says any HCE entering a transaction with a physician organization of less than 25 physicians. However, then you say less than 25 is exempt, but greater than 25 made subject to the requirement. So shouldn't it be greater than? Because you're supposed to be exempt if you're under 25. And I do somewhat recall the negotiations for the legislation since I was involved.
That is a good call out. So the statute defines providers, and excluded from the statute is any entity with less than 25 physicians. Mm-hmm. So 25 or under is not considered a provider. So that means if you're under 25, you don't have to file. So it's not an error in the slide. It's basically saying who must file. They're exempt from filing if they're under 25. But if they're being acquired by an entity that is over 25, then the acquiring entity has to file.
It doesn't say acquiring, it says entering into a transaction. And as we just heard, the definition of transaction is very broad. So there's a difference between acquiring, if you want to say acquires, and we can discuss that. So I just think there's some lack of clarity in the language, and because you're saying transaction. This is not acquiring, this is transaction. And transaction, as you described, is very broad.
Yes, and I should correct that. Pardon me. It is in transaction. We often think of these in terms of an acquiring physicians or a group acquiring a physician organization, but it is if you are entering into a transaction with less than 25 physician organization, the entity that is over 25, regardless of what type of entity it is, okay, maybe it's a health plan, maybe it's a hospital, that entity has to file. But because the under 25 is not considered a provider under the statute, the under 25 does not have to file.
Okay, so just to clarify, and actually then that also gets into the next slide. You're basically saying, because also it's a little confusing if you actually go to the next slide, what you said about the 10 million. I mean, basically, if one of the parties in the transaction is more than 25 million, then they need, because in transaction, I mean, I assume there's two parties, right, or more. But if any party in the transaction is over 25 million, then they have to file. Because I mean, are you talking about, oh, well, if I have 125 million, they each have to file separately, right? Even though it's for the same transaction. So just, it's a little confusing because I'm not sure, for example, annual revenue of 10 million or more controls, and then in the transaction, any AC satisfying the above 25 million threshold, well, the 25 above 25 million threshold, I assume, has to file because they're over 25 million. But are you saying, therefore, a separate filing needs to be made by the other entity that has 10 million for the same transaction? So I'm just trying to clarify, like, how many filings are we talking about for a single transaction?
Yes, both entities would have to file. So again, the jurisdiction covers healthcare entities. So if you're a healthcare entity under the definition in the statute and the regulation, you have to file. Then you look to see if your transaction, if you meet these revenue thresholds, if more than one of the parties to the transaction meets the threshold, they both have to file, or all three have to file. However many meet the definition here, the threshold, they will have to file. So there could be multiple filings for a single transaction. And let me just say that that's very intentional, because as I move on to explain what's required in the filing, each party will be providing information about itself and its description of the transaction and what it thinks the benefits are. And so we want to hear from the multiple parties in a transaction. So,
Sheila?
Yes.
Okay, well,
Yes, my question is on, let's see, yes, this slide as well. And it has to do with the last bullet. So we're talking about HPSAs, health profession shortage areas. California has had a broader definition of kind of medically sensitive underserved areas, so MUAs or MUPs. Was thought given to expanding the definition of these areas?
Yes, we gave a lot of thought to this last bullet point, and we looked at, first we wanted to look at underserved areas. And so we thought, how do we do this? And how do we do this for purposes of a regulation? Because a regulation is a rule that entities have to follow. So what's a rule that they can follow? And the Office of Administrative Law, of course, has to approve it. So we wanted to tie it to something that already existed. So we did start with medically underserved areas, MUAs, but those aren't updated as frequently. And then, you know, there's federal law, there's state law. And so what happens is those aren't always updated as well. And OSHPD had a long history of looking at medically underserved areas for our workforce development programs. And so they use sort of, I'll call it an amalgamation of MUAs, these HPSAs, and other things. So we thought, okay, what is something we can tie this to that's verifiable, where the data is can be tested, and that's updated often enough that it's going to meet the needs of what we're really trying to do. And so that's why we chose the HPSA. And that's why we also chose if you're serving at least 50% of the population in a HPSA. And Vishal may want to add something on this, because we spent a fair amount of time and he dug into some of the actual data, because on the CHS website, there is some dashboard information as well. So someone could go and test themselves against the HPSA and the CHHS dashboard. Go ahead, Vishal.
Yeah, for the medically underserved areas, those are broader, and sometimes those designations are determined, and some of them haven't been updated since the 80s or 90s. So HPSA versus HPSAs, HCI, the Office of Workforce Development staff is heavily involved, and they do these surveys, and they do it every 3 years, so it's more current and refreshed. And it's more in terms of targeted, in terms of the sub-regions it considers. It doesn't capture too much. It is kind of narrowly focused on those regions that are vulnerable and have a lack of providers.
If I remember rightly, HPSAs, they have primary care, mental health, and I believe dental. Is the idea here that if a provider is in any, so regardless of what the provider type is, that they would, if they met these criteria, would have to file, or are we narrowing it down to, primary care provider only if they're in a primary care HPSA?
It's broader. It's the broader. So if you are a healthcare entity located in a HPSA or serving 50% of the population of a HPSA.
Thank you.
So I guess I do have some concerns. So how for a HIPSA, because you say 50%, 50% of what? So what is the average patient population of a HIPSA? So I mean, we're talking about, and we start thinking about certain rural communities, I don't know, if that number starts getting very small, basically we may be throwing sand into the gears of, people trying to serve, essentially shortage areas, right? We may actually discourage people because we're going to create this whole bureaucratic process around there. So certainly, we want to be sure people are protected, but we're not talking about, basically this is an or. So this may not be very large entities. These may be very, very small entities, but because it's a very low population area, it triggers now, and then we're going to be talking about the process and how many months and so forth it'll take that triggers that. So they're not some large entity necessarily that's coming in because it's an or. So it's not 25 million or more, 10 million or more. It's just like, okay, I'm a provider who happens to get 50% of the people in a HIPSA that may not be very well populated. And now, in order for me to do any transaction, I now have to go through this whole process. So I just want to be sensitive to, so what exactly, who are we talking about when we talk about 50% of people residing in HIPSA? Is that how small does that get? Are we going to try to be micromanaging or putting into a microscope versus, hey, I can go work in the suburban area, bring capital there, et cetera, and I don't have to worry about all these loopholes, but all these hurdles. But if I go in a rural area, now I'm going to find myself, right? So why bother, right? So et cetera. Or people want to invest in these low-income rural communities. Are we going to make it more difficult for them? So so it'd be helpful to know exactly who are we talking about who's affected by this.
Thank you for the comment. It's 50% of patients residing in a HIPSA, but I do understand your question, and I do appreciate it. Again, you have to go through these 3 bullets to see if you meet any of these, and then I'll move on to the circumstances of the transaction. So it does not mean that just because you are in a HIPSA or you serve 50% that you have to file. That's the first question. The next test is, does your proposed transaction meet the 9 circumstances, which I'll go back to. But I do want to emphasize that I've heard your comment and I do appreciate it, and that's why these are proposed regulations. So as we get to my overview of the comments that have been given so far, you may find similar comments as well. So, all right. So I had gone through the first 4 of the types of circumstances that would trigger a filing requirement. So I'll go now to numbers 5 through 9. So there's a total of 9. So does the transaction contemplate an entity negotiating or administrating contracts with payers on behalf of one or more providers, and the transaction involves an affiliation, partnership, joint venture, accountable care organization, parent corporation, MSO, or other organization? So this is really, are you negotiating on behalf of that entity? Is that what that's creating? Number 6 involves the formation of a new healthcare entity, affiliation, partnership, joint venture, or parent corporation for the provision of healthcare services in California, projected to have at least $25 million in annual revenue, or have control or assets related to the provision of healthcare services valued at $25 million or more. Number 7 involves a healthcare entity joining, merging, or affiliating with another healthcare entity, affiliation, partnership, joint venture, or parent corporation related to the provision of healthcare services where any entity has at least $10 million in annual revenue. But we have intentionally excluded clinical trials and affiliations that are for the purposes of graduate medical education. And number 8 changes the form of ownership of a healthcare entity, including but not limited to the change from a physician-owned to a private equity-owned and a publicly held to a privately held. And then number 9, I'm going to tie that back to some of the comments that Assistant Deputy Director Howard mentioned from the advisory committee. Number 9 are those serial transactions. So number 9, the healthcare entity that is a party to the transaction has consummated any transaction for the provision of healthcare services in California with another party to the transaction within the prior 10 years. So if you've done a deal with any other parties in the proposed transaction in the past 10 years, you would meet the circumstance of number 9. Did you have a question?
So again, the definition of transaction being as broad as it is, I mean, I get if you do acquisitions or, et cetera, but when you say any transaction in 10 years, I mean, so I appreciate we're trying to get serial, but I wonder, is this too broad? I mean, if you're in the same healthcare market, you have a relationship, is it any transaction? I mean, that's the thing. I mean, I can see certain transactions raising concerns for serial, et cetera, and consolidation, but any transaction, I just wonder how many different types of things each guy, staff is going to be weeding through and reviewing, because of this. So I am concerned that what happens is that we're, going to be doing a lot of chaff sifting to try to find the significant things, and whether this should be narrowed to the things that would trigger more significant concerns.
Thank you. I appreciate your comment. And it is any transaction related to the provision of healthcare services.
Sheila, did you want to speak to kind of the direction the FTC is going on this as well?
Yes, the FTC issued recent revisions to its merger guidelines, and they are very similar to what we're doing in terms of the expansiveness and the broad look and the broad approach. So many of these factors that we have in these 9 are much aligned with the new FTC guidelines. And I see that, did you want to add any more? I just saw that Board Member Mitchell had a comment.
I actually just had a question. Thank you. So would this apply to, say, on-site clinics for an employer with a rural agricultural population or something?
If it met the revenue thresholds, it could. Yeah. So we go through the test of the revenue thresholds for the entities, those first 3, and then it would go through. If it met one of the 9, it could, and it sounds like it could. I'd have to know more about the transaction, but it sounds like it could.
Or if it's in a HIPSA, right?
Yes.
That's what I was
yeah,
talking about.
I mean, that it
That
doesn't
would
just
fit.
have to hit them. It could be that second
If
reason,
they're
in which case
serving.
it would hit everybody. Yeah,
Right.
yeah.
Thank you.
Yes. There are a lot of lots of hypotheticals, that people.
But that's an example, and
That
that's
is an
probably how it would play out.
Exactly.
Yeah. Just, it makes perfect sense to me to shoehorn in the littles when they're having a transaction with a larger. I mean, we talked, I think, at the last meeting about one of the ways consolidation plays out, which is you have sort of the gradual eating of smalls until you have a big with market power and leverage that creates competition challenges. On the HIPSA piece, I think I agree. I think it's really important that we not inadvertently create an environment where we are essentially adding a disincentive to go into areas where we ought to be creating incentives. It is a challenge to have investments in some of these areas, and we just need to be mindful of that. And real or perceived new bureaucratic, obstacles are gonna they'll factor into people's decisions. I mean, they just do. So I do think I also HCI gets to spend as much time with as much as seems like a good idea, but it does seem like not sending over the everything to them and then asking them to sort through it, but targeting what goes may make more sense. But I'm mostly concerned with the first concern, which is creating any disincentive to invest in these areas. I mean, we face these challenges all the time and are forever trying to entice anybody who will come to some of these areas into these areas because we can't get healthcare in these areas.
I appreciate that. And I think there is a balance to be struck here. And that's why we're going through draft regulations and soliciting comments. So I do appreciate pointing out maybe some unintended consequences that could occur. And on the other side of it, looking at the HIPSA's and underserved areas in general. That's also, it's vulnerable. They're vulnerable areas from the large players who go in and acquire, and then there's no competition. So it really is a balance, and I do appreciate your concerns here about maybe disincentivizing smaller players from going into underserved areas. Dr. Carlisle?
I think I was going to make the comment that you're speaking to right now, which is fully understanding the impact of lack of transactional capacity in these small areas. There is another unintended consequence, which is that these are very small areas of very small numbers, and it's very easy to kind of have a significant change overwhelm or overcome the area that may not meet other thresholds more easily than in larger areas. And this could have a significant impact on a very small population that could be vulnerable.
Yeah, thank you for pointing that out. We gave a lot of consideration to that and also looked at the FTC guidelines, and we recognize that even in the shift of one specialty provider or a small group of specialty providers in a small area can drastically change the area in terms of consolidation and access, and the impacts can be very far-reaching.
Just on this point, I share your perspective, Dr. Carlisle. I think I do appreciate the approach that you've taken here. I think the burden of these filings as compared to the due diligence that goes into these kinds of investments, I think is relatively small, and I don't think we're being served well by the lack of transparency into the market as we are. And what, besides the mandate to provide review of these transactions, what is especially meaningful to this piece of the statute for this board, I think, is that it's one of the very few prospective looks into what's happening into the market. Most of our data is looking back 18, 24 months. This is one of the few insights that we have as to what's coming down the pike. And so for me, an approach that collects more information, whether or not we're scrutinizing every single transaction in meticulous detail is a different question, but capturing more is a good thing. And I think the one place where I'm concerned here is the thresholds seem high to me, especially to the degree they're out of alignment with that piece of the market that the Attorney General regulates right now, which I think is at a $3 million threshold. And I did want to also just pick up on what you mentioned about the FTC rules. One thing that stood out to me in the FTC draft publication is some real concerted attention to labor market impacts and employment practices. That seemed omitted in the regulations, and I'd like to hear your thoughts as to whether that's going to be a piece of the analysis going forward.
Yes, to your question about labor and the impact on labor, it is part of the analysis, and I'll highlight that for you in one of the coming slides. And I do appreciate your remarks because, again, OCA's charge is public transparency. OCA does not have the authority to stop a transaction. Our charge is to collect information that's informative to the public. So while these are very broad thresholds and may pull in a lot of transactions, it is consistent with the charge to collect information that is informative to the public. And not, as I emphasized at the very beginning, not every transaction will go to a full cost and market impact review. If you look at Massachusetts, which is a state that's been doing this for more than a decade, they've done 10 in approximately 10 years. So while we may be getting a lot of notices of transaction, it doesn't mean that they will go to a full cost and market impact review, but it will inform the public ultimately. So for time's sake, I'm going to keep moving along, if that's all right, unless there's another pressing question on these. Okay. Okay.
Thank you. I'll be brief. I just really would like to underscore and hopefully monitor the impact on these rural and underserved areas. I understand we have historic data, but what we are seeing are growing maternity deserts, primary care deserts, and anything that in any way discourages providers from going into these underserved areas, I think we have to be just very careful about. And then just tying it back to Director Landsberg's comment about wanting to get to new payment models. We right now that's very hard to do in California because of regulation, and so if we are somehow creating additional barriers to value-based payment transactions, particularly in rural areas, I just think that will be an unintended deterrent of some of what we're trying to achieve.
Thank you. All right. So when do the healthcare entities need to file their material change notices? It's 90 days before entering into the agreement or transaction per statute. And so we have defined entering into the agreement or transaction. And I will just briefly say that the definition really is the closing date of the transaction. So looking at the bold language on your slide, the date any party's respective rights vest in a binding agreement, where all contingencies to the agreement or transaction are met or waived. And that is the closing date. We did receive some comment, and I will say that we will be clarifying that even further to give more exacting regulatory language on what the closing means and the actual time frame for filing. So what's in the material change notice? So first of all, we will be creating, we're actually in the midst of creating our electronic filing system. So healthcare entities will go into the portal and register. When the healthcare entities submit their material change notice, it is under penalty of perjury. So when they answer the questions and when they write their narrative, it is under penalty of perjury, as well as the documents that we will be requesting, because we request supporting documentation for all of the information in the material change notice. So there's specific information. This slide just highlights it. The actual regulation has many more detailed items and questions for the healthcare entities to respond to. But it's basically a description of the transaction, the necessity, the public impact, the benefits, whether the transaction has to go through review by another entity, state or federal, and then prior healthcare services related to the transactions with the same healthcare entities. I've talked about that a little bit before. And then I just want to focus on the post-transaction information, because this is, what we're talking about. We're looking at what are the expected competitive impacts, and what are the entities going to do to mitigate those potential impacts. We're looking at current healthcare services provided and the post-transaction impacts. So when you mentioned the deserts, the maternity care deserts, we have listed out some items in terms of behavioral health care, reproductive services, LGBTQ plus services, also. And then the next bullet is all about changes to staffing levels, employee wages, benefits, working conditions, and employment protections. So those are all parts of information that we will be collecting about the transaction. What are those post-transaction impacts to services, to labor? And that will be part of our review. All right, this is really what happens after the entities submit their material change notice. OCA has 60 days to determine whether to conduct a CMIR. The clock for the 60 days does not start until OCA determines that the submission is complete, meaning all the information has been provided and all the documents were furnished. If there are additional documents that OCA needs, OCA has the option to stop or toll the 60-day clock, and it will begin again once those documents are received. At the end of the 60-day period, OCA will then issue a waiver, letting the healthcare entities know that they do not have to proceed to a cost and market impact review, or conversely, that they do have to proceed to a cost and market impact review. At that time, the healthcare entities can request a redetermination of OCA's decision to conduct a CMIR. We've built in a process where the healthcare entities have 10 business days to ask the department to reconsider, and then the department the office, OCA, has 5 days to respond and determine whether the CMIR will be waived or it will proceed with the CMIR. At that time, when OCA is ready to proceed to the cost and market impact review, it will post all of the supporting documentation for the transaction on its website. I know this was a question at the advisory committee meeting as to when would the information be posted. Let me be very clear that the notices themselves will be posted when OCA receives them, again, consistent with OCA's mission to inform the public, but that OCA will not publish the documentation, the documents, until it decides to go to a cost and market impact review. And then the cost and market impact review period is 90 days, but OCA may extend that for 45 more days if needed. At the end of that time, OCA will issue a preliminary report. The parties and the public will have 10 business days to comment on the preliminary report. And then within 30 days, OCA will issue a final report. And the parties cannot implement their transaction until 60 days after the final report has been issued. All right, so these are the factors for OCA's consideration to issue a waiver or conduct a CMIR. And these are the factors that were laid out in statute. So in regulation, we have clarified those factors. For factors that OCA may base its decision on to conduct a cost and market impact review. So if any one or more of these factors is a factor that OCA feels warrants a CMIR, OCA can proceed with a cost and market impact review. So I'll just give you a minute. I won't narrate every single one of them, but basically you can see that they relate to availability and accessibility, negative impact on costs, the ability to meet the spending targets, lessening of competition or creation of a monopoly in the geographic service area, the direct effect on a general acute care or specialty hospital, a negative impact on quality of care, and then to the earlier question about a healthcare entity located in a state and an out-of-state entity, and what impact that could have on services in California.
Just to clarify, so under this approach, you would have reviewed Kaiser's Geisinger acquisition as an example?
If I run it through the analysis, it probably meets one of those thresholds in terms of the dollar value. It would probably meet more than one of the 9 circumstances. And then when we went to review it, F would certainly apply.
Thank you.
All right, please. Oh, hang on one second. Let me go back. So the statute lays out factors for OCA to consider in conducting the CMIR. And I have mentioned this in other presentations to the board and to the advisory committee about a balanced approach. And we do want to look, there are efficiencies that can be achieved through affiliations. And we do recognize this. I know it seems as if it's all about the negative, but there are efficiencies and there are benefits. And so we will be collecting that information as well. We have been, outlined in our regulations the kinds of questions where the entities can give a very full description of what those would be and maybe how those wouldn't be achieved without the transaction. So to implement the statute, we have developed in regulation the factors that will be considered in conducting the CMIR. So OCA will look at the business size, its relative market position, and then, these factors as well, which again, I won't, for time's sake, read it in its entirety. But again, we're going back to the same themes of availability, accessibility, quality, lessening of competition, raising of prices, and again, whether the parties have been parties to other transactions in the past 10 years that have been below the thresholds that we've set in regulations. So we're looking at, in the actual CMIR, we're looking at more comprehensive information, and those will be conducted by an expert. And then final factor is any other factors the office determines to be of public interest. And again, that is consistent with our charge to collect information that is informative to the public. And finally, this last slide is a visual for you on the time frames and the timeline. So the healthcare entity submits its notice of material change, and OCA has 60 days to conduct the preliminary review. It won't always take 60 days. I know that is a concern, but if you look at what other states are doing, sometimes it's sooner, So it really just depends. It will be a transaction by transaction, case by case situation. We are just beginning this program. We're just beginning with implementation. So, and we have future years to sort of see what happens, to see the speed and the types of transactions that take less than 60 days. I see a question.
Yeah, thank you. So just to clarify, because if what you said is that the entities file 90 days before they're supposed to close their transaction, correct? So no, we anticipate we're going to consummate the transaction in 90 days, so we need to provide all the paperwork. OCA has 60 days to sort of say waiver, no waiver, with some processes there. But if we decide that we want to do a CMAR, they cannot proceed with that transaction until, well, you start adding up. I mean, by the way, 60 days is 2 months, 90 days is 3 months. Then you start going through and, you have 90 days plus 45 days, et cetera. And then you can't actually implement the transaction itself until 60 days after the final report. So that's starting to add up to around, 8-9 months or so before the transaction. So you have a deal you're working on, and time is money. It's not just money. It also could decide on whether. So what happens is that they're going to anticipate we're going to try to do this in 90 days. But you could actually, so yes, I agree. OCA doesn't have the authority to stop a transaction, but you can essentially kill a transaction by delaying it. And so now we're talking about something that's out 8 or 9 months, I guess one of the things that I hope that we're doing is we're collecting all these filings is that we actually monitor what actually happened to the transaction, especially if it's going through this delay, because it's possible the delay itself can kill the transaction. Now, maybe that's a good thing. Maybe it's not a good thing. And so I think, that's a concern. And again, if we're particularly targeting HPSAs and so forth, if we're finding out we're having lots of transactions basically terminated because in areas of need, because they're concerned about delays, and frankly, I think what Board Member Molds mentioned, my concern is I agree that we don't want people targeting vulnerable populations. At the same time, I don't want people to not invest in vulnerable populations as well. And we could be discouraging people from doing because they see this bureaucratic hurdle. And I will give you a non-healthcare example. When there's a shortage of housing around here, veterans have a hard time buying houses because they have to go. They're getting VA loans, and the VA certainly has very important rules to protect veterans from buying crappy houses and so forth. But what happens is that other people are swooping in with cash buyouts and others. We're not just talking about private equity firms. We're talking about just individuals and so forth. And so people don't want to sell to veterans because they have to do a VA loan. It just takes too long, right? They could have already sold their house and it's done. So I don't want that to start happening to low-income communities. So perhaps you can also speak to how HCI will prioritize certain types of reviews so that we can move them along so that we don't have a situation where, someone's going to anticipate, hey, there's a possibility that our transaction, which we wanted to happen in 3 months, 90 days, isn't going to happen for 9 or 8 or 9 months, right? And all the consequences therein of delaying a transaction.
Yeah, we appreciate you flagging the concern about timeliness, and certainly it's something that we're hearing from stakeholders as well. So we take it seriously, and these are some outside timeframes, and certainly we would endeavor to move it quickly. We understand that a delay can kill a deal. By the same token, that the legislation was focused on this because of the very real impacts on cost and affordability. So we'll be very aware of it during implementation.
So I guess the commitment I'd ask for staff is that actually you collect data and report to us what happens to these transactions. So in other words, how many transactions actually terminate or they withdraw their filing because essentially they decide not to do that.
We'll certainly take that. We're building a system to track all of this, and we can certainly take that under submission.
Yes, and the regulations do allow for withdrawal at any time, and we have heard these concerns. And I would like to point out too that the regulation requires 90 days before the anticipated closing date. That doesn't mean that the entities can't file sooner and start the 60-day clock sooner. That 90-day advance notice is the deadline, right? So when you look at deals that do happen, you'll read a lot of press releases that NTA and NTB have reached a definitive agreement to do XYZ and subject to stakeholder and regulatory approval. And then when you look in the press release for when that deal is done, it can be quite a long time out. So I hear your concerns, and we do appreciate them. And this is the beginning of our program, and we will be watching how these transactions play out. But again, it will be a very case-by-case basis. So I'll move on very quickly, for time's sake, to the comments that we received at the public workshop on August 15th. We had, at one point, 120 people attending the public workshop virtually, and we had approximately 20 people in the room, give or take, some that came in and left. Approximately 13 people gave comment on the regulations, and a very good participation from a wide variety of stakeholders, including unions, physician groups, health plans, hospital systems, private equity, consumer advocacy groups, medical hospital, and nursing associations. So we really did appreciate the feedback. In general, there was appreciation for the detail of the proposed regulation and for the lengthy time that will be given to comment. And as I mentioned earlier, we are continuing to receive comment on these proposed regulations until August 31st at 5 p.m. So here were some of the takeaways from the workshop. Some felt that the thresholds were too broad and went beyond OPA statutory authority, while others said they were not broad enough. We heard, varying opinions on the thresholds were too low and the thresholds were too high. So in terms of the monetary amounts, several commenters opposed the inclusion of management service organizations as healthcare entities. And then there were comments on the timing, as we heard here today as well. So as I mentioned, we will be doing some more clarification on the timing for filing of the notice, but it is basically 90 days before closing, but we're going to clarify that so people can really figure out how to comply with the rule a little bit easier. Same comments about the length of time needed to review the notices and conduct the CMIRs, and a suggestion for expedited review. And commenters appreciated the confidential process because we have allowed for healthcare entities to designate certain documents as confidential to receive confidential treatment. And there are certain documents that will automatically be given confidential treatment, and those are set forth in the regulation. And one commenter recommended that additional documents would be considered that certain documents would be considered expressly confidential. So adding to that list of automatic confidentiality. And then one said that we should have the healthcare entities attest that they've always kept the documents confidential. So when they are requesting confidential treatment, they need to also attest that they've always kept them confidential in the regular course of business. And then this is the final slide on the takeaways. A couple more comments on thresholds for filing requirements. One group was also very interested in the Geisinger purchase and wanted to ask OCA to look at the source, request the source of funding for the transactions, and to collect evidence to determine that the transaction is beneficial. So I mentioned that we would weigh those things, and this commenter emphasized, concrete evidence, collecting concrete evidence of that beneficial factor. And then there were multiple comments about the factors for review in the CMIR, both when to conduct one and then in conducting one. Several commenters appreciated the inclusion, as I mentioned, of reproductive services, but wanted to make sure it clearly stated that it was the full panoply of reproductive services. So sexual health services, also including contraception, abortion, LGBTQ+, and health services. Others mentioned behavioral health services, and again, their emphasis on labor market impacts. One actually went so far to say that labor market impacts should be the sole reason for conducting a customer market impact review. And then again, there was comments on either side that our review criteria was too broad, and some said not enough. So commenters suggested public hearing, including public hearing in the regulation. We did not do that, but it doesn't mean that OCA does not have the option to do that. And then fees. And I do want to clarify something about fees here. When a healthcare entity submits a material change notice, it will not be charged a fee. There are no fees associated with filing. So as you said, how many filings are we getting? Multiple entities will have to file for a single transaction, but they will not be charged a fee. OCA will seek reimbursement for its cost of review. So when OCA uses the services of an outside vendor, expert economist, or otherwise to conduct the review, it will then bill the healthcare entities for reimbursement of those fees. And I'm happy to take questions.
We've had a robust discussion already, and we are late on time, but are there other questions or comments from board members before we move to public comment? David.
I was wondering if you could say more about confidentiality, and does the statute, what specification is there in terms of defining what is confidential already?
So the regulations allow for the healthcare entities to submit a request for confidential treatment. So for example, we'll be asking for the term sheet, and if they say certain items in the term sheet should be confidential, they'll let us know what they are, and we will be requiring them to submit a public-facing version. So that public-facing version would have the proposed redactions, and then OCA would receive the full confidential version. OCA will then review the request for confidential treatment and the basis that the healthcare entities are relying on. And it is expected, if you're going to claim that a document should be treated confidentially, you need, as a healthcare entity, to have been treating it confidentially all along. You can't suddenly claim that something that was public is now confidential. And then, like the Department of Managed Healthcare, we actually followed a lot of what they do for their material change transactions, for their material mergers, and for their license modifications. They have a very similar process to request confidentiality. They designate certain documents that will always be treated confidential. And typically those are financial trade secret type level of documents.
That was helpful. That was one of my questions. So if an entity claims a document is confidential, is that claim being treated under perjury and so forth? Like if they're telling you it's confidential, but then they go tell an investor, call all the details in that document, can you call them out on the carpet for that?
Yes, we consider everything submitted with the material change notice as submitted under penalty of perjury. So when you get to the end of your filing and you check that box, it's under penalty of perjury.
Back to the confidentiality piece, this will not include pricing. Is that correct? Sort of, will it track the federal requirements for transparency of pricing and price impacts?
If they have to make it public for under another law, then it would be very hard to argue that it should be treated confidentially. Yes.
Okay.
So we would consider that, And again, as you point out, they're submitting under penalty of perjury that they have in fact treated these documents as confidential in the regular course of business. So if that conflicts with their federal responsibilities for compliance, there would be a big disconnect there.
And then last question, in terms of the benefit, I'm sure every proposed transaction is supposed to make healthcare wonderful. Will you be requiring significant evidence of the benefits?
We are asking for all supporting documentation for anything asserted in the material change notice. So it will be something verifiable, hopefully, if they've complied. And again, that's where we say this is a complete submission, or no, this is not a complete submission.
And to follow up on that, do you have the authority to require information a year or 2 years after the transaction has been completed to see whether what's been promised has been delivered?
Our charge is the prospective review of transactions, but I would say that there's nothing in our statute that precludes us from following up, because I will point out, and this question has been asked before, a cost of market impact review isn't always tied to a transaction, right? The legislature gave us the authority in the statute to conduct the cost of market impact review based on consolidation, access, failure to meet spending targets. So there could be a possibility that we would be doing a look back. And our statute also gives us authority to conduct studies, research studies. So a research study could look at a particular type of transaction or very similar transactions or a particular area and say, we want to do a further deeper dive study on that. Massachusetts does this. When they're not collecting notices, their staff is also doing research studies.
But the statute doesn't contemplate, like, specifically going back and seeing if what they asserted actually came to pass.
Right, because our look is perspective.
Yeah,
That's a good point.
I mean, I'm sure that many of my academic colleagues will be interested in trying to evaluate this, but it may often be difficult to get the information they need to do that unless you are able to require some of it from the entities, which I hear maybe a step too far. David?
Thank you. You made note that several commenters oppose inclusion of MSOs, and that does seem to be a bit beyond what the statute said. So can you explain why MSOs are being considered payers?
Based on the statute definition of payer as someone who arranges for the provision of care, it's a very broad definition, one of the broader parts of payer definition. That's where we believe that MSOs fit in.
Okay. As someone who helped draft the statute, I might have a slightly different opinion, but we'll see. Okay. All right. I just wanted to have a better understanding of, aside from you're just saying cite the statute, how do you think of them as payers? Thank you.
Well, as you know, MSOs perform multiple functions, some more limited than others, some much more expansive than others. And some serve as payers, some serve as utilization review, some combine all those things, some do the claims processing. So under the language of the statute as we have read it, we feel it fits into the broad definition of, I'll have to get the actual statute.
That's okay, I know it.
Okay, if you know it, the provision that is our broadest, any entity that arranges for the payment delivery.
So you're saying only certain MSOs will be, not all MSOs?
The regulation?
Because as you said, that there's a variety of roles they can play.
The proposed regulation defines all MSOs.
Okay, so I think that's where you may be going beyond the statute. Again, I think so. It's some concern. There are entities that play different roles. And I think, again, this is back to how many different filings, et cetera, and how much we're going to get, right? So, because, frankly, you have you can have a limited amount of staff. And so what kind of filings are we going to start talking about if the role of the MSO is fairly limited, yet now we're going to require that they have to file all these things, right? If they're playing a substantial role, that's one thing. But let's not try to require everyone to file and, have to file basically large amounts of paperwork. Some of it's very important. That's why we asked them to do it. And then, have to have staff sit there and sort out what's really meaningful and what's not. So, I'm hoping for a more nuanced view on this. That's really based on what we're really trying to get at, and not just like, can we have everyone send everything to us and then we'll figure out how to sort it out at the other end when we get this huge, because what happens is that if this is your regulation, the lawyers are going to tell everyone like, hey, by the way, just because you are this, even though what you do isn't that related, you have to file, right? And that's where I think we start creating problems for both this office, because we're going to get a lot of stuff that isn't really what we, that really isn't directly related. And then, of course, we're now forcing people to spend time and money doing filings for things that aren't particularly relevant to, why we want these, studies of market consolidation and, of course, spending targets.
Well, respectfully, I appreciate your comment. Thank you very much. And, by virtue of the fact that you're an MSO doesn't mean you're an automatic filer for anything that you do. That's why we have the monetary thresholds. That's why we have the 9 circumstances. That's why we've been going through the analysis of what is the transaction. So it's not just because you're an MSO that you're now going to have to file, no matter what or regardless, for everything you do. That's not the case. There are thresholds that have to be met and circumstances. And I just want to clarify that, but also to let you know I do appreciate your comment.
We probably want to move on to public comment.
We do. Okay. Thank you, board members, and thank you, Sheila, for that excellent presentation. I invite comments from members of the public.
We will now recognize members of the public for comment on this agenda item. To ensure equitable access, we will alternate between folks in the room and individuals attending virtually. Those in this room may line up at the podium. Those attending virtually may raise their hand. Those dialing in can press *5. I will now start with the individual at the podium. Please go ahead and make sure that the microphone light is green. Thank you.
Good afternoon. I'm Jamie Ostroff. I'm the General Counsel for the California Medical Association. The Office of Healthcare Affordability has been charged with the critical task of promoting accessible, equitable, high-quality, and universal healthcare for all Californians. To accomplish that task, it has been given the power to adopt emergency regulations through January of 2027. In what looks to be a rush to achieve its goals through this rulemaking authority, however, the proposed cost and market impact review regulations deviate from the statutory authority granted to the office in important ways and create important or potential legal challenges to those regulations that will only delay OCA's important work. There's two overarching issues I'd like to point to here. First is, as I said, the regulations go well beyond the statutory authority as well as the underlying legislative intent. Second, the regs fail to recognize the practical realities of the market and the transactions they intend to regulate. As far as the statutory authority, the sweeping breadth of the transactions captured by the proposed regulations provide the office with open-ended authority to scrutinize any healthcare market transaction at its discretion for whatever time and whatever cost to the healthcare entity. While the statutes do not grant the office with the power of approval, which has been addressed by the board, the proposed regulations effectively allow it to stop a transaction through delay and increased cost. Regarding the portions of the statute that go beyond, or the portions of the regulation go beyond the statute, Dr. Pan referenced the inclusion of MSOs. We disagree with the assertion that MSOs fall within the definition of payer. In fact, an MSO, many instances, operates as an agent of a physician organization. By incorporating MSOs into the statute, you've effectively expanded the definition of physician organization beyond what it was statutorily intended to mean. Additionally, the addition of affiliates, subsidiaries, and other entities that don't otherwise satisfy the definition of a healthcare entity subject the regulations to legal challenge. Additionally, the types of transactions that require notice is expanded beyond those defined under the statute. I see my time is about to end, so I'll just point out that the concern here is that the regulations as presently drafted will merely delay the implementation through legal challenges as they go well beyond the statutory authority granted the office. Thank you.
Looking to hands raised virtually, seeing none, noting that we have roughly 100 people attending virtually. Moving back to the individual at the podium in the room, please go ahead and make sure the microphone light is green.
Thank you so much. Kim Stone of Stone Advocacy on behalf of the California Orthopedic Association. Appreciate the opportunity to make public comment here as well as to provide written comments. And among other things, many orthopedists are what you would call littles, are in small practice groups of some of them are 1, some of them are 5, certainly not 25 or 24 practitioners. And the statute specifically defines a physician organization subject to the regulations as a medical group, medical partnership of 25 or more physicians. We are concerned that some of the triggering mechanisms would potentially include, we want to make sure that the triggering regulations do not overtake the statute's prohibition on those smaller practice groups. If it was 2 practice groups of that their combined total would not be larger than 25, but they had 10 million or a large million in revenue, we want to be we're hopeful that the regulations would not intend or serve to overstep the statutes, leaving them off the table. look forward to submitting written comments, and thank you very much.
Thank you. Looking back virtually, seeing no hands raised, reminding our virtual attendees, if you'd like to make a comment, please raise your hand. If you're dialing in, please press *5. Looking back the room, the individual at the podium, please go ahead and make sure the microphone light is green.
Slightly colorblind. I hope you're hearing me right now. Ben Johnson with the California Hospital Association. Thanks for the opportunity to provide comment. We share the concerns expressed by other stakeholders here as well as by board members that the regulations as drafted go beyond the legislative intent and authority, that they could seriously impede even basic market and operational activity among healthcare entities and ultimately would impair access for California's patients. First, note that we think that changes need to be made to provide reasonable noticing and materiality thresholds, really to focus the office's efforts on the most impactful transactions, as is consistent with the statute, which states that the office should analyze those transactions likely to have significant effects. To faithfully operationalize this intent and allow the office to devote its limited resources to where it can achieve this greatest impact, it really must change these materiality and noticing thresholds. And the current draft regulations do not do this for a couple of reasons. First, the inclusion of any change to the operations as under the definition of transaction would mean that transactions to, say, purchase a new EMR platform or signing up to be a network provider with a health plan or leasing a facility. All of these are changes that would impact the operations of healthcare and therefore would have to be noticed to the office and ultimately delay those transactions or disincentivize them altogether. So we think at minimum it is essential to narrow this scope to remove transactions that are in the ordinary course of business. And we think, in addition, that materiality thresholds should be raised, such as to the FTC filing thresholds, as the office is indicating that it wishes to model its efforts after. Note quickly that the office has used what we think is the Massachusetts filing threshold as its inspiration, which was set in 2015, and there's been 30% inflation since then. We also have a range of concerns around the timelines not being clear and speedy. Yes, we agree it could take 8 months. This is a month or 2 months longer than comparable other offices would take in this process. And we have a whole range of, we'll have a whole other range of recommendations and changes that we'd like to see as these regulations are finalized, really to allow the office to focus its effort and not be overloaded by a great burden of notices and information. Thank you.
Thank you. Looking virtually, seeing no hands raised, reminding virtual attendees, please raise your hand and you will be unmuted. If you're dialing in, press *5. Moving back to the room, the individual at the podium, please make sure the microphone light is green. Go ahead.
Good morning, everyone. Diane Shaputiski with the California Orthopedic Association. A very interesting discussion this morning amongst board members. And actually, I was struck by some of the comparisons that were made. I believe, Sheila, in your comments that you said that several of the proposed regulations are very similar to what the FTC is proposing, very similar to what has been implemented in Massachusetts. And I think you also referred to the DMHC. I think it would really be helpful to the board to really have a side-by-side comparison to know how similar is similar and how we compare to Massachusetts, particularly since we're using Massachusetts as sort of a benchmark of a state who has gone through this before. And you're saying really has only done 10 filings in however many years they've been in operation. So I think using vague terms is a little troubling and really would like to see a comparison. And maybe you've already prepared that, but I don't think it's been provided to the public. The second point I'd like to make is that in the board discussion this morning, I thought there were some terribly important points made and some confusion in some of the terminology and the broadness of the proposed regulations, and I think that's what is leading to some of the opposition from stakeholders in the room. So I think more precise terms and definitions of which MSOs are included and which ones are not would be very helpful to the overall regulatory packet. And I was also sort of struck that some of those very important points that the board made this morning were really not included in the main takeaways that you presented from the work group meeting. So I'm not sure those types of issues were even really discussed. So finally, I would ask the board to consider maybe convening another meeting of the work group so that they could work through and talk through some of the comments that have been made. Thank you.
Thank you. Looking back virtually, seeing no hands raised. Still noting that we have roughly 100 virtual attendees. Inviting individuals in the room who'd like to make comment to step up to the podium.
Good afternoon, Bill Barcelona, America's Physician Groups. I'd like to provide comment in my 2 minutes on subsection C6, which includes the formation of new entities as a trigger for filing and market review under the draft regulations. I'll present you with a scenario that I used in the work group last week, where you have an RBO, which is an entity which accepts alternative payment models, namely capitation, applying for a restricted license, which would up their acceptance of capitated risk to global risk under Knox-Keene rules. And this is a transaction which would be favored under the OCA legislation because it would represent a transition further away from fee-for-service payment models to alternative payment models. And it is a very costly process at DMHC that takes over 6 months and can cost anywhere between $1 and $2 million to obtain the license. Under subsection C6, this triggers a filing and market review because obviously it will include a transaction that is ultimately worth more than $25 million. But by definition, the entry of a new entity into the market decreases consolidation in the market and it increases competition. And so these rules create a disincentive, if you will, or a barrier to entry into the marketplace by creating a process that involves more time and more cost. And I think we should revisit how these regulations create that type of disincentive to increasing competition and decreasing consolidation. Thank you.
Looking back virtually, inviting members of the public to raise their hands or press *5 if they'd like to make a comment. Seeing no hands raised at this time, moving back to the room and the individual at the podium.
Beth Capella on behalf of Health Access California. Unlike most of the other speakers, we would prefer lower thresholds. The Attorney General currently uses a $3 million threshold for hospital mergers. We'd also note that about 95% of the hospital mergers reviewed by the Attorney General are approved, mostly with conditions. We also would appreciate clarity that the definition of revenue applies to total revenue from all sources, not merely net patient revenue. We further appreciate the clarity of staff and hope for clarity in the regulation that market reviews can include reviews for market failure, such as for Monterey County, about what you have heard so very much. We also appreciate the clarity of staff today verbally and would appreciate it in the regulations as well, that information that is designated as confidential must have been maintained as confidential and not otherwise be public. We do also ask that you look at including behavioral health services. The definition tends to focus on physical health services rather than behavioral health. as in recently enacted legislation, SB 855 and AB 988. And again, we would ask that it be the full range of reproductive health services and the full range of LGBTQ services, including gender affirming care, that be included. We also would ask that the potential benefits be accompanied by some sort of evidence of what those benefits would be rather than mere assertions about the potential benefits. And we understand that many transactions are characterized as having positive impacts, but documented and measurable impacts on quality and cost should be included. Finally, we would encourage staff to have sufficient time to do reviews and sufficient fees to fund the work. Thank you.
Looking virtually for hands raised, seeing none. Inviting members present in the room to step to the podium.
Good afternoon, everybody. Mark Aprea with Aprea and McKaylee. I'm here on behalf of the American Investment Council, a trade association representing private equity firms around the U.S. First of all, I want to thank staff for their incredible hard work and engagement with the stakeholders, and we very much appreciate the time and attention they've paid when we have engaged with them on not only the statute, but the proposed regs. We want to address a few items, and we're going to provide greater detail in written testimony, but the time frame for submission of notice, we believe, should be clarified. We come at this to look at it predominantly from the perspective of ensuring that folks are able to clearly understand what is required of them and when, and so that there is no misunderstanding as to what triggers a filing and what are the timelines that are associated therewith. So we have presented that at the workshop, and we'll continue to do that in our written statement. The definition of material change, we think, should also be appropriately limited to exclude minor transactions. And in the workshop, we addressed the issue of making clear that revenue calculations are limited to California-derived revenue. We also pointed out for reference that Massachusetts defines material change to mean a transaction that will result in a provider organization having a near majority of market share in a given service area or region. And Oregon talks about it is triggered by a party with $25 million or more in annual revenue. So we would agree to look at the other states and how they've addressed those issues. We'll be happy to submit greater testimony in writing. Thank you all.
Thank you. Looking virtually, looking for hands raised, seeing none. Moving back to members of the public in the room, inviting you to step to the podium if you'd like to make a comment.
Seeing none, thank you to the board members and to the members of the public and to Sheila for really a very rich discussion this morning. We will break for lunch. It's 12:25. Come back at 5:01, please, to start the second half of the meeting. Thank you all. Well, good to see everybody. I hope everyone had a good lunch or some lunch. I think we will do roll call to make sure we have a quorum, please.
All right, roll call. Dr. Mark Galley. Dr. David Carlisle.
Here.
Dr. Sandra Hernandez. Richard Kronick. Ian Lewis.
Here.
Elizabeth Mitchell. Here. Dr. Richard Pan.
Here.
Don Molds. Please speak into the microphone.
Sorry, we have reassembled a quorum. I'll turn this over to Deputy Director Bagani and Michael Baylett from Baylett Health for a discussion of total healthcare expenditures measurement. Vishal.
Thank you, Chair. So I'll be turning it over to Michael Baylett, and I will be co-presenting on this topic for total healthcare expenditures measurement. I'll hand it over to Michael to kick it off.
Good afternoon, everyone. Nice to be here with you again. See if I can remember how to advance the slides. There. Okay, so we haven't met for quite a while, and so I want to remind you about total healthcare expenditures, total medical expenses. When we met in June, we talked about adjustments to the healthcare spending target. We talked about work to be done on quality and equity adjustments, organized labor adjustments, and then methods to ensure confidence in the findings. And so we talked about confidence intervals when reporting and risk adjustment. And what were some of the things that OCA was thinking about? Subsequent to that meeting, I think it was subsequent, yeah, we met with the advisory committee, and not only did they talk about CMIR, but we also talked with them about really everything that you've talked about today, because it was their first meeting. So it was a big catch-up meeting for them, but we shared with them what we had shared with you, and we asked them to react and share essentially their recommendations to you to inform your recommendations to OCA. So what we're going to do today is we've got a two-part presentation. First, Vishal is going to share the advisory committee's feedback on the total healthcare expenditure conversations we've had, and then I'm going to share with you some information about which entities will be measured relative to the spending target. We haven't talked about specifically which entities. We've talked about classes of entities, but we haven't talked about identifying exactly which entities will have their performance measured. So that's the plan for the next hour or so. Any questions or comments? Okay, Vishal.
Thank you. So I'll be covering the feedback we received on the advisory committee with respect to the topic of total healthcare expenditures. So we have this kind of subheading here of inclusion of specific plans and types of spending in THCE. So a lot of the comments that we received pertain to types of spending that should be considered by OCA, including workers' compensation, long-term support services, dental-specific plans, and vision-specific plans. But there was kind of different opinions among the group in terms of what should be considered for future years for OCA's work versus kind of what OCA should focus on now, given the data that's available. And then OCA, regarding the second bullet listed here, there was also some discussion about capturing spending not incorporated in our current proposed methodology, including membership fees that some organizations fund for their patients, such as One Medical, direct primary care, alternative medicine paid out of pocket, for example, acupuncture, and then and then behavioral health paid out of pocket, which has been a topic at the board level as well. And then unpaid claims was also raised as well. The advisory committee members supported inclusion of spending data from other niche programs or kind of specific federal healthcare programs. So correctional health care was mentioned, as well as TRICARE. Next slide. And then as far as data collection and reporting, there was some conversation around medical debt, and then health savings accounts and flexible spending accounts, HSAs or FSAs, in terms of, to what extent OCA could get data on that. And then another consideration that the advisory committee some members brought up is OCA is going to disaggregate THCE by market, including commercial, Medicaid, Medicare markets. There was some interest in going down a level further into product types, so measuring THCE by HMO or PPO product types. The advisory committee members also suggested how could we improve the capture and analysis of encounter data for capitated payments. And then moving on to the next category of suggestions, there was some discussion about types of hospitals in terms of hospital outpatient departments, and then there being different flavors of them, including community outpatient, and the types of services that each of them may provide, and being able to compare costs in that way. The advisory committee also signaled broad support for OCA's contemplated methodologies for measuring services and entities. One member suggested looking to commercial ACOs and Medicare Shared Savings Program contractors for identifying provider entities, for which we can hold accountable to the spending target or for data reporting. Next slide. And then as far as risk adjustment, there was some members of the committee did voice concerns about OCA's consideration of using an age and sex risk adjustment approach. They mentioned some concerns about exacerbating health inequities and leading to selection or avoiding healthier patients or avoiding sicker patients. Excuse me. And then members also indicated they would like to continue this conversation about risk adjustment at a future meeting. So that kind of wraps up the high-level themes that we heard at the advisory committee, and I do want to turn to board member Lewis in case he has anything to add.
No, I think you summarized it well. Thank you. The only thing I'd add is, a number, as you said, commented or suggested, including having an expansive set of data that we're collecting into THCE. At least 3 people I heard said some variation also of, yes, but let's not let the perfect be the enemy of the good, and recognize that over time we'll be able to capture more information, but that we shouldn't get bogged down in the perfect definition, so that the statute's implemented with some urgency.
Ian and Vishal, I wonder if you could provide some thoughts about a process question. The advisory committee is advising us as we are advising OCA. I appreciate the summary. I confess to not having listened to the advisory meeting, which I assume is available. Do you have suggestions of how we might, as a board, incorporate or respond to or deal with the suggestions of the advisory committee, and how we can sort of make this a little more real? Because from the short summary, I don't feel competent in kind of saying, oh yes, I think this is a really good point that we should have considered more closely or not.
The recordings are available online, and staff did do an excellent job in summarizing the minutes. It's several pages long and do capture kind of the back and forth and the questions that were posed. So you would get the essence of what happened without having to watch the full meeting. Elizabeth, do you?
Yeah, I don't have much to add. I think it's an important question on the structure. So yes, they are like this meeting. It's a Bagley Keene Open Meeting Act, so it is a public meeting. Folks can watch it. So the process that we're proposing and open certainly to board suggestions about a different approach is that we do these summaries and then that the board member or board members who are in attendance can add to it. Of course, many of the groups that are on the advisory committee are also coming and giving their perspectives here. So it's sort of one of many avenues for a broad array of stakeholders to convey their views. I would say a lot of the same themes, issues that this board has brought up, and frankly that Vishal and I get questions about when we're presenting in the community are, how are you going to capture out-of-pocket expenses like for behavioral health and other things? So I think there's a lot of common themes.
Rick, what I've observed in other states that have a similar arrangement is that when the presentation of the other advisory body is done, that the members of a body like this one might say, oh, that's a good idea. It wasn't something that we identified, but we think it's something that we want to suggest that the state move forward with.
I would like to vouch for special appreciation to this stuff too. I mean, I did a close side-by-side comparison to this on my own notes, and I did a really excellent job of following up those things that have not come up in others. I don't recall us discussing anything
And then I guess sort of question both for staff and for us of what process, if any, makes sense to have done some board discussion of these issues, either ones that we haven't previously discussed or ones that we have but now have additional input on and might or might not want to change our recommendation. I mean, I hear the concern about risk adjustment. Speaking for myself, I'd be interested in listening more to that. I probably don't have a real open mind on that myself, but other board members may feel differently. But there are other things where we might well change our previous thoughts. But we don't really have a kind of agenda item or process to do that.
Well, but I think that's precisely why we're presenting these summary slides that you may have had a chance to read it ahead of time, or if not, that we're presenting here. So yeah, absolutely, if there's a new approach that's suggested by the advisory committee that the board would like to follow up on, now's a great time to do it. We're happy to take guidance moving forward.
I can share that one idea that they put forth that you all did not bring up, but that we subsequently discussed, was this idea about should we collect data for the commercial market separately for PPO and HMO. Okay, that topic didn't come up here. It did come out of that group though. And so we wound up having internal conversations about, hey, is that a good idea? Is that something we should run with?
Which is a good example of something that we need to be sure is in our process to bring back to this group to say we're now looking at that piece.
Okay. Yep. David?
I'll add along those lines. I noted how quickly the advisory committee dispensed with something that took some time on our part, which is additional data such as TRICARE and correctional health systems. So I assume that was a fair degree of consensus on that item at the advisory committee.
I wouldn't say there was consensus. So just so you all know, the first advisory committee meeting was quite long. It was a full day, and I would say we did a subset of all the slides that you all have gone through. So Michael did include slides about should we include TRICARE, should we include Indian Health Services, should we include correctional, and like you, many there said, of course, if you're asking us, do we want more data? Of course, we want more data. So with a group, as you all know, it's 27 members with pretty disparate perspectives. So we're not indicating that this is feedback. It's not necessarily consensus.
Yes. And also, I would just echo Rick's point about risk adjustment. It's obviously complex. There are unintended consequences when you go down that slippery slope. but it's probably something that I know we'll revisit at some point.
So I think our next agenda item is, Michael, your presentation.
Yeah, so we're going to talk now about essentially who gets measured. So as a reminder, the statute says the office shall develop requirements for payers and fully integrated delivery systems to submit data for the three purposes you see enumerated here. And it makes references to healthcare entities. We talked about healthcare entities before lunch. We're going to talk about them again here, but they're going to be defined differently for this purpose than for CMIR. And so I'm going to walk sequentially through proposed approaches for doing this work and ask you to reflect on it. I'm going to start first with this little schematic, which I've shared before. So these are the 4 levels of reporting of total healthcare expenditures. We're focusing on the 2 on the right now. And I'm going to start by talking about payers. So when we began thinking about which health plans should be required to submit data, and I'm going to note that submitting data is a precursor to reporting on performance. So when we were thinking about who's going to submit data, we thought about a few criteria. So the first, how to focus on the payers that represented the most spending, because there are a lot of payers, many of them quite small. How to avoid collecting data from payers that are too small to contribute to statistically meaningful results. And more generally, how to balance the administrative cost of collecting data, validating data, analyzing and reporting it with being complete. And I want to make clear that the effort to not only for the plan to generate data, but for the state to collect it, validate it, analyze it, and report it is significant. And it's the same for a small payer as it is for a large payer. So we were trying to balance these concerns. And so here is the proposed approach. Health plans with at least 40,000 covered lives in any market, and we're defining markets as commercial, Medi-Cal, and Medicare, would be required to submit total healthcare expenditure data for all 3 markets. You might not be above 40 for all 3, but you submit for all 3 if you're above 40 for 1. This would mean that nearly all the Medi-Cal plans would be reporting, except for some very tiny specialized plans. Altogether, this would give us 99% of the commercial and Medi-Cal markets and about 97% of the spending in the Medicare Advantage market based on our estimates. So there are still a lot of payers that would not be included, but they don't represent a lot of spending. Right? And to make this a little bit more real, using a snapshot of the most recent data that we have, these are the payers that would be required to report. So you can see we've got 14 commercial, 22 Medi-Cal, and 12 Medicare Advantage. There are some organizations that appear in all 3 markets, and there are some that occur in only 1 or 2. Yeah.
Thank you. Like Centivo or Collective, like on the plan side, they're more TPA, but will they be in here?
All right, so I don't know who they are, but are they only TPAs?
No.
Okay, so to operationalize this, there's going to have to be a schedule whereby using data as of a certain date, OCA will have to do an assessment of who's in the market and who's got covered lives that hit the 40,000 threshold.
Okay.
And so I would expect that this list will change over time, not only because of new market entrants, but because of departures, mergers and acquisitions. This will not be a fixed list.
And just to say, we're working closely with our sibling departments, so DHCS and DMHC, and can certainly get lists from them with enrollment data.
And just to clarify, for ERISA arrangements, if they're a carrier, they report, or how's that work?
So for the commercial markets, the payers will be asked to submit total healthcare expenditures for their full population combined.
Okay. So that includes if they're a carrier for ERISA arrangements. Okay.
Yeah. And most TPA business in the state is with the plans that are in the commercial market. Okay, so Vishal?
And I'd add that the Medi-Cal plans also include the county organized health systems. So just want to, pause here in case the board has any additional questions about our approach for including payers for collecting total healthcare expenditure data.
So does this go around the ERISA preemption for submission of data for self-insurance?
So that typically applies to claims or record level data for APCDs under the Go-Bay decision. So the OCA data is different. It's summary data. And as Michael was saying, the commercial payers would submit a combined submission, including their self-insured enrollment and then their fully insured business.
And I just want to flag that this 40,000 member threshold was the same that used by HPD. So all of the plans that we plan to get aggregate data from, we're also getting HPD claims data on.
This threshold makes sense to me. It'd be useful, I think, to see a list of the plans that are below the threshold. I doubt I will change my opinion of this, but it'd be nice to know who we're not getting. Assuming that you have this list.
Yeah.
Yeah.
Yeah, we have that. We could share that.
Okay, so we move on to providers. This is a little more complicated. We actually talked about this a little bit before. OCA is going to develop methods to assess performance for different provider types. We've talked about this. For THCE, we are looking at a variety of organizations for which spending can be attributed through direct or inferred primary care relationships. I'll explain inferred a little bit later on. Okay, but basically the way that we connect spending for individual patients with accountability for larger provider organizations is through a relationship with a PCP. And that's how all of the other states with spending target programs do that. And the types of provider organizations can be systems, medical groups, IPAs, FQHCs, so long as they have employed or contracted or somehow affiliated PCPs, that's an entity for which we can do measurement. Okay? Yeah.
Yes, Michael, along those lines, just a quick question. So are you saying that if you have a out-of-plan utilization, is it still attributed back to the PCP organization?
Mm-hmm. Yeah, so when measuring total healthcare expenditures for the organization, you're measuring total spending for its patients, regardless of where they receive services. In fact, even if they receive services out of state, it's included. Okay, and the idea being that the primary care relationship is one that is designed to be holistic in care for the patient population, and so that's why we're being holistic in terms of spending. That doesn't mean that the primary care clinician or the organization with which the primary care clinician is associated has obviously control over all of the utilization and spending. That's not the case. But is there an assumption of significant influence of how care is delivered? Yes. And that's the rationale for using the PCP link. Okay. OCA separately anticipates developing methods for performance for other provider types, including hospitals, but that we're not talking about that today. That's a topic for another day. We're focused on measuring total healthcare expenditures, and that's through the primary care relationship. Okay, so I want to talk about work that we've been doing to think about how to do that attribution using direct or inferred primary care attribution. Right, so just as a reminder, what we're measuring for purposes of the spending target is change in per capita spending over time. Okay, the spending target is not a target for PM spending value, it's how much spending changed from the prior year to the year that followed. And we're going to be using aggregated data from the reporting providers. And within total healthcare expenditures, we have total medical expense and admin and profit. Total medical expenses, as a reminder, is paid claims, non-paid claims payments, and the patient out-of-pocket obligation. Okay, so that's just a little refresher. So let me talk about attribution and what we've been thinking about. So we're talking about creating rules, and so this would be guidance for payers for when they are preparing their submissions to OCA that would direct them that they should use this relationship to the PCP, as we've talked about. And as David asked, this would be spending not delivered not just by the PCP or the PCP's affiliated entity, but by anybody who provided services for the patient. Okay, so as we've been thinking about the instructions, we've had to deal with some challenges. So first is we don't know which PCPs are affiliated with which provider entities in the state. Okay, California does not have a provider directory that we can tap into right now for this purpose. Also, we know that sometimes primary care clinicians operate in multiple organizational settings. So I'm at an FQHC 2 days a week, but I work for a health system the other 3 days a week. Health plans themselves do not maintain lists of, that identify which clinicians are practicing exactly where. And of course, PCP affiliations are subject to change all the time for many reasons. Okay, so so there are some challenges to thinking through attribution. OCA has engaged stakeholders in thinking about this, and so we've had conversations asking them for their input. We've got 2 different advisory groups, one of commercial and Medicare Advantage plans that's met a few times, and a new one of Medi-Cal plans that met last week for the first time. And so we have been asking them for their input and using their wisdom to try to craft an approach. So what might that approach be? So we're considering an approach that uses PCP selection or plan assignment for HMO and PPO populations. So that means both I, as a member, picked a plan, I picked a PCP within the plan, or I didn't pick a plan, but the health plan assigned me to, I didn't pick a PCP, but the plan assigned me to a PCP. Okay, so when I talked earlier about direct and inferred, I'm going to describe those two as direct because the plan knows exactly the connection between the member and a PCP. But I also talked about inferred. There are a significant number of members for whom we don't know who their PCP is. What we do know is where they have received services because we know where spending's occurred. And so the approach for people for whom we cannot identify a PCP relationship is to, and we are testing this right now, is to look at where the preponderance of their professional spending was and to use that to infer that there is a primary care relationship there. Okay, that's how we're trying to get around this lack of certainty about PCP relationships. And this is really all because of the amount of capitation within the state. If we had fee-for-service claims for the HMO population, then we'd be able to see Rick had 5 appointments with Dr. Bailett. Dr. Bailett must be his PCP. Okay, but sometimes we don't know that when there's high levels of capitation.
Actually, along those lines, that example, I think is exactly what I was going to speak to. Spending is different than encounters. So where you see more encounters, you might see that relationship. But if you have a major trauma or something going on outside the network, you may be out of the state or something, that bill, that expenditure may be very large. So if you're using expenditures to identify the PCP relationship, it might be different than the relationship that you identify using encounters.
Right. So we've got to test different approaches here. Right now, we're focusing on professional expenditures because we want to leave out all the facility spending. Okay. But might we try some other iterations where we say, well, non-procedural professional services, or I don't know if we can even do that. I think we do know there's a lot of professional capitation, so that gives us some insight. But what we would really like to know is that it's a PCP, or at least that it's outpatient office visits for a PCP. But capitation doesn't give us insight to be able to see that.
Michael.
So we're testing using preponderance of professional spending. And I think we'll need to do some work in time to see how strong an indicator that is. Are we going to get some false positives? Yes.
When there is capitation, it doesn't seem that there should be much of a problem. You know who the capitation is being paid to. And whatever group the capitation is being paid to is responsible for my care.
Right.
We've also had this conversation before, and I think continue to differ as to the quality of the encounter data underneath that capitation.
We just hear over and over and over that the encounter data quality is poor.
You know, the Medicare Advantage encounter data is not poor. I've been working with it. How is your data? Yeah, and cover California.
Yes, I know.
And
You
cover
both shared this
California.
last time, but when we talk with the plans, that's just not what we're hearing. So I don't know where the truth lies, but they've been pretty consistent in that messaging.
But in any case where there is capitation, it seems like there should not be a problem ascribing who's responsible for me, because somebody's getting my capitation.
Right.
So
well,
even if you don't have the encounter.
Some entity.
Yeah. Well, that entity is the responsible entity.
Right.
And going back one slide though, we sort of you mentioned as a problem, but didn't really discuss solutions other than saying you were asking the payers, how do we know which physicians are practicing together or where they're practicing?
Yeah. So
you know, AHRQ put a lot of effort and energy and money into creating a compendium of health systems using Medicare billing data. They paid Mathematica to do this, but also David Cutler at Harvard under a grant did another version of this and has put together using billing data a compendium of health systems that identify physicians and what health systems they're part of or what groups they're part of by looking at where they're billing with. So for each NPI, what taxpayer ID number are they primarily billing under? And the issues you raise of physicians, you know, working in 2 different places is certainly a challenge that, you know, the contractor dealt with. And I think, you know, did a pretty good job of resolving. So you might look at that if you haven't yet as a potential way of aggregating phisians into groups.
I'm sitting with David at a Red Sox game this coming weekend.
All right, I'll talk with him about it.
Maybe I'll ask him about it. All right, thanks. I wasn't aware of that, but we'll look into it.
Yeah. Who are they playing?
The Dodgers.
no comment.
So we're also working with the plans to assess the consistency with which they might identify relationships between providers and systems.
Yeah. And as I'm sure you know, IHA here has put a
Yes.
lot of effort into this as well.
Yeah.
And,
Yeah.
if you haven't yet, kind of making sure you understand what they've done and whether that can be adapted would make sense.
Yeah, we have had some consideration.
Richard?
No, thank you. And certainly this is a challenge. I mean, I'm just thinking about patients who have some chronic condition where perhaps that condition is primarily managed by a particular specialist. So cancer patients being managed by an oncologist, where they may have a primary care physician, but because they have cancer, sort of defers. And if they have, let's say, a PPO, right? And so sometimes people actually specifically want a PPO if they especially have a chronic condition because they may have a particular specialist they always want to see. They may not care as much about the PCP and some of the other stuff. And so they want, and you know, I take care of children. So, you know, you have children's hospitals, other types. Some of these specialists are fairly rare. So I do wonder how that plays in terms of how we're trying to attribute, right? And most of the spending is happening on the specialty care, right? The chronic condition. It's not the general checkup stuff. So at the point where the specialist is taking more response, you know, basically doing more ongoing care because it's mainly in their realm of their specialty versus the sort of routine care that and other stuff. You know, just wondering how and you know how that gets attributed. And of course, you know, when you have chronic condition, that's where you really spend the money. So so I'm just trying to figure out how sometimes that, you know, whether it's some.
Yeah, so sometimes that might be a problem, sometimes it won't.
Right.
So
yeah.
if my PCP and my oncologist are
Right.
part of the same medical group,
yeah, you're fine.
and I'm measuring the medical group as an accountable entity,
Right.
I'm okay.
Right.
But if I'm going to a specialist who's part of another health system,
right,
then yes.
Yeah. So I mean, it'd be interesting to see how often that actually kind of happens. I imagine it happens more in the PPO world because that's why people get PPOs. Actually, that's one of the most frequent reasons I hear people why they sign up for a PPO for that. So and so it'd be interesting to get a sense of how big of an issue that really is.
Right. Well, and how much of the time are they really shopping and going outside versus going to a specialist to whom their PCP referred them? Right. So I mean, using PCP attribution is not perfect. I mean, there's lots that we're doing that's not perfect. Is it good? I think so. But we will find scenarios where someone said, oh no, I went shopping for my oncologist and I found someone who's 100 miles away and that's where I'm going to go. In that case, for that one patient, is the PCP really accountable for what's happening with that patient? Probably not.
There's no good B plan also, right?
Right.
Yeah, so that's, you know, I was going to.
The B plan is what Massachusetts did, which is only use HMO patients.
Yeah,
I don't
right.
think that's a good
Not
B
a
plan.
good B plan.
But I think a good B plan is to measure separately for patients who are assigned or have signed up with a primary care physician, primarily HMO patients. But in the case of Covered California, maybe also, you know, the PPO patients who have been assigned to a PCP to measure separately for that group and for the group that we're attributing.
Yeah, I think there are all sorts of interesting and maybe even necessary analyses that should be done even after the baseline report to understand what we're catching and what we're not catching.
Right, but those data, we'd have to ask the payers to report separately on patients who are attributed versus patients who were assigned or have assigned themselves.
Well, I would say with HPD, it would be possible to do that without having the payers submit.
Yeah.
I think.
Maybe, and I think, you know, we're putting a lot of, you're we're having a lot of discussion, putting effort into what are we going to ask the payers to do?
Yeah.
And it seems to me like a sensible thing
Yeah,
to ask the
yeah.
payers to do.
There will be many points at which OCA can say, what should we do and what should we ask, the payers or one or two friendly payers to do to give us some insight.
I thought we were talking about what to require all payers to do.
Yes.
Yes,
I'm saying that we've just been talking about limitations with primary care attribution.
Right.
Okay. And so one way to test really how limited is it and what percentage of time are people not getting their oncology within the health system where their PCP is to do some
that through the
ad
HPD,
hoc
yes.
analysis. Yeah.
But the ad hoc part makes sense, but it also makes sense to me to systematically ask the payers who will be reporting to be reporting separately on spending for patients who are attributed versus spending on patients who are
Got it.
assigned.
Okay, I thought you.
And I guess at some point, basically at the beginning, at least you get a sense of scale, right? Because we're like, oh, it's this tiny little portion versus, oh, now it's actually something that we think actually moves the needle on our overall plan.
Mm-hmm. Okay, so thank you. So where we are right now is continuing to gather input. We actually have a survey out to a sample of plans right now, and looking forward to getting information back from them to refine this. I don't think we are quite there yet in terms of identifying which provider organizations should be assessed, but that's okay. We've got a little more time to figure this out. And I think ultimately we'll be able to come back to you and say, having done all of this work, here's what we've heard, and here's what we're thinking in terms of the provider organizations for the baseline report. And I don't know, the baseline report is the baseline report. That there's room for OCA to make modifications as it learns through experience over time.
And is part of your survey asking the payers what they're doing now on attribution?
We're asking them to test different ways of doing attribution, particularly doing the incidence. I want to note there will always be a sizable amount of unattributed spending. Okay, and it will be surprising how much there is, but there are a lot of people who do not have a primary care relationship, and also note there are a lot of people who in the course of the year don't seek out services. Okay, so you'll see that in quite some time after the baseline report is done, but know that there will be attributed spending to different provider organizations, and then there'll be all this other spending that's not attributed.
Michael, I wanted to just kind of emphasize the second bullet about OCA gathering input from stakeholders on approaches to attribute spending that cannot be attributed using the approach above. So the PCP selection or assignment, that's going to be kind of in terms of a hierarchy, that would be kind of the first step. And it's really that second step when that can't happen that we're trying to solve for. And we are actively exploring some options and getting some technical assistance from plans. And the problem really is kind of this, as we said in this meeting about the one-to-many relationship and how do we those affiliations between the PCPs and the larger provider entity that we're trying to measure. So we are actively working on that, and we will return to this group with some options in terms of what's feasible.
Okay, so I think you've already asked a bunch of questions. Yes, should we go on? Anything else?
Yeah, we can move on.
Okay, so last slide is to give you a little bit of a preview. The content that I had to share today was rich but limited in scope. We're going to have a much broader scope for you for the September meeting. So the advisory committee will have met the day before you, so we will have very fresh reporting on what they had to say We're then going to give you a summary of the major design decisions for the baseline report submission that OCA will have made for collecting 2022-23 data. It won't be every little detail, but it will give you a sense of here's what OCA is going to ask. We'll review the process and timeline for the regulation promulgation. The public comment process will be finalized. And then we're going to transition to the next phase of our work, which is talking about the spending target itself. We've only been talking about the methodology for measuring spending, but we have not talked about what the spending target should be. Yeah, right. We're going to, the order of operations is first talk about the method for arriving at it and then the value itself. So this will be the first of a multi-part conversation. We're actually not going to talk about any targets. We're just going to talk about methodology and methodological options and invite you to consider what they are. If there are some options that we haven't identified and you want to introduce them, you'll have an opportunity to do that. And then we will continue in October to delve into the topic more fully. Ultimately, talking about values and duration and adjustments and all sorts of.
Thank you. I'm not sure the right time to ask this, but or maybe not at all, but are you considering how to integrate the new TIC data, the CAA data, the new transparent hospital pricing information? Will that all be integrated into the data set? Like the negotiated rates that are increasingly available from the federal regulations?
You mean for total healthcare expenditure reporting? No. So the data that we're using, it comes from the payers, and they're going to say, this is what we spent. These are the payments that we made on behalf of our members and on behalf of the patients served by these provider organizations. It's potentially a valuable data source, but it's not what we're going to be using to measure total healthcare expenditures.
Okay. And then we talked about out-of-pocket spending. You're going to have some way of thinking about that.
So out-of-pocket spending is going to be measured two different ways. When we ask the payers to report, they're going to report on what we call allowed spending, which is both what the provider received and the patient out-of-pocket obligation. But we're separately going to ask the payers to report just on the patient out-of-pocket obligation. So we can see that and track it over time.
But on that, and this is rehashing or relitigating old discussions, and I know it's a bit of a tangent from getting regs out on what payers have to do, but I don't want us to lose sight of the other spending that we have. Many of the board members have said it's important to be including in a baseline spending report. Public health spending, out-of-pocket spending on behavioral health. Even this, I wonder a little bit about, the payers will report on the patient responsibility, but we all know that all that money doesn't get paid all the time.
Right.
And trying to get some estimate of what fraction of that actually is paid, which I'm not sure I have any great ideas about how to do that, but some ideas, kind of not ignoring that, I think would be useful. So, given, I know we're focused on what we're going to ask the payers to do, but I don't want us to lose focus on the other parts of spending that we all think are important as we're putting together this baseline report.
Yeah, I think there are opportunities and actually a necessity for all types of complementary analysis in addition to the spending target. The spending target is not a be-all and end-all for understanding healthcare spending and affordability. and certainly not what's driving healthcare spend.
But, and also, Rick, I mean, to your point about, we've had the conversation very, very early on. Do we include TRICARE? Do we include any health services? What are the best data sources for non-covered out-of-pocket expenses to consumers, which we've heard consistently is very important, and we agree. So we are looking at those data sources, and we'll circle back in September to let you know where we're headed on all of each of those pieces.
Great. Thank you. Because I think that the behavioral health out-of-pocket is the one that's got the most kind of interaction probably with what we are measuring. That over time, we would hope that behavioral health out-of-pocket goes down and what health plans are paying for behavioral health actually goes up. And so trying to keep track of those two things together would be important.
I mean, I think after we finish this work process of developing the spending target methodology, it would be appropriate to have a conversation about what do you all as a board think that you and OCA need to know in order to drive improved affordability of healthcare in California.
Yeah. And I note for the record that our chair has arrived, and I gladly yield the gavel to Dr. Galley.
And given that I'm catching up, please don't quite do that quite yet.
All right. I'm still chair for another 30 seconds.
Eat his lunch. Come on.
Queen for a day.
No, keep it up. Thank you for giving me a second. Sorry to not be here on time. Was doing other good and important things as well, but pleasure to be here and keep on going, Chair.
Repetitive of I think points that have been made so far, but I would be deeply skeptical of appreciating that attribution of primary care is by far and away the best single tool that we have. I think is going to be really inaccurate when we start looking at PPOs, and would be good to think about alternative ways of figuring that piece out, and to the extent, because we have both populations at CalPERS, to the extent that we can be helpful in trying to sort through that, but presumably, there's got to be an imperfect but better model for PPOs given the low penetration of primary care and the fact that, to Dr. Pan's point, people go into these expressly because they don't want to go through primary care. We don't like that, but it's just sort of a fact of the population and the experience.
So, John, your concern is that we're missing accountability for spending because of the percentage of people in PPOs who are not going to primary care?
Right. Okay. Right.
So we are going to talk in future months about accountability of other entities.
Yeah.
And so that might be the opportunity.
Yeah, and it might be worth saying, okay, so for an HMO population, this is clearly the best tool we have for, and we can, for just to use our experience as an example, we can differentiate between people who use primary care as a focal point for their care within a PPO and people who clearly are not. And so you could even take a PPO and subdivide, and then start looking at how you would get at the rest of the population who isn't doing that. But I think there's some good thinking that could take place that may help with that problem. That's my only point.
Okay, I think that's it.
Robust discussion from the board, and ready for public comment on this item.
Thank you. We will now recognize members of the public for comment on this item. To ensure equitable access, we will alternate from those in the room to those attending virtually. We have previously started with those attending in the room. I'm going to look virtually for any raised hands at this point. Seeing one, I believe it's Mohit Ghosh. We will turn it over to you. Please keep your comments to 2 minutes, and you are unmuted. Please unmute on your end.
Thank you so much. I hope people can hear me. I'd like to make a couple of comments on behalf of Anthem. One is that we don't believe that the ERISA question has been resolved to the extent to which was discussed earlier. And so that's one comment. The second comment I'd like to make is that there's been a lot of very, very robust discussion around PCP attribution, and that's very, very important. We're happy to be a part of the groups that are working towards getting this right, specifically on total healthcare expenditures. But there is, to the point that was just being made, a significant amount of spending in the state of California that is not PCP attributable. And to, in some ways, adjust that to essentially create a narrative that says, okay, we can create a total healthcare expenditure model that is PCP attributable, therefore controlled under one or two TINs, maybe, is very, very difficult to do. So I would suggest to the board that we continue this discussion in all of the advisory groups that are being made available to industry, as well as not just the health plan side of the house, but equally importantly, the provider side of the house, because we do need to get this right. I echoing comments made from different members of the board, but very importantly, I think we are in a position of simply not getting the baseline report correct. And if we do that, then anything we build upon a false baseline doesn't really make sense. Thank you.
Thank you. Turning to the individual in the room at the podium.
Beth Capel on behalf of Health Access California. To add a few points to the discussion, we concur with the approach of focusing on the top 99% of the market, or 97%. We think that is sufficient. We recognize there are a lot of relatively small health plans and health insurers in California as well. And in terms of market entry and exit, I would note that Oscar, I believe, has already exited the market since this list was compiled. So markets keep changing. With respect to reporting, it seems to make good sense, and the plans are well able to do it, to separate PPOs and HMOs from the beginning, rather than doing it post hoc or ad hoc. Similarly, what the patient paid or what the consumer paid, as opposed to allowable or obligation, can also be determined by the payers and should be, and separated from what the payer paid. And in terms of tracking for total healthcare expenditures on covered benefits, obviously, when somebody pays cash for what should be a covered benefit, as happens all too often in behavioral health, but is not, then that creates a different set of reporting challenges. But we concur that over time, more of that should shift to the health plan paying rather than the consumer paying out of pocket because of the lack of timely access. Finally, we would note that California has, there are different types of provider directories. We understand Massachusetts maintains some sort of registry of affiliations. There's also the information that Dr. Kroenig provided on what has been done at the federal level. A provider directory, which is really a plan directory of contracting providers that's consumer facing, is required under California law, but sadly that law is not enforced or complied with. So there should be such a thing, but there's not. So, or one per plan. So, but we do think that assembling the information on affiliations is going to be an important part of this work. DMHC does look at network reporting. And so that's another source of information. Thank you.
Turning back virtually, in the order that the hands were raised, Janice Rocco, go ahead, please.
Thank you. Janice Rocco on behalf of the California Medical Association. I'm going to comment on two of the issues that were talked about, the risk adjustment methodology proposal and then attribution. Some of our members were lucky enough to get a presentation recently about the Office of Healthcare Affordability, which included THCE and the proposed risk adjustment methodology. I will say our members were reacted strongly to hearing the staff recommendation to risk adjust solely on age and sex. The concerns included worry that OCA in doing this could decrease access to care for some populations and cause greater health inequities. We know this is not your intention, so we would urge you to risk adjust for health status and consider geography as well, so that providers aren't disincentivized or even punished for taking on high risk or high cost patients. In terms of attribution, it's helpful to hear some of the comments today and that the plans are being consulted and that eventually the providers will as well. At a previous meeting, there was discussion of attribution to the primary care physician, even if the patient had never seen the primary care physician. And so I do think it'll be helpful to hear feedback from physicians and other providers about options before the decision is made about attribution. So thank you.
Thank you. Alternating back in the room, the individual at the podium, please make sure the light is green on the microphone.
Hi, Ben Johnson with the California Hospital Association. Just echo a few of the comments that were just said. We believe that getting patient attribution is absolutely critical for credible estimates of spending and ultimately implementing the cost target methodology. And so appreciate the engagement. We look forward to working with the office as once you move into collecting information and feedback from providers, and ultimately look forward to further discussions about how to make sure that that process is transparent to the public and to the provider community as well. Thank you.
Moving back to the virtual room, in the order hands are raised. Hector, please go ahead.
Hi, everyone. My name is Hector Aspecuera, and I'm here with Alicia Ortiz, who is going to speak about her experience with hospitals pricing in Monterey. As you know, Natividad, CHOMP, and the Salinas Valley Health. So Alicia, can you state? Alicia is going to be speaking in Spanish, and then I'm going to translate for her. Okay.
Mi nombre es Alicia Ortiz y vivo en la ciudad de Marina, California, y en el condado de Monterrey. Le pedí a don Héctor, estoy un poco nerviosa, le pedí a don Héctor que lea por mí lo que escribí. Gracias.
Go ahead, Luis is going to read her statement.
Okay, bueno, good afternoon. Y estoy aquí porque es importante dar mi testimonio acerca de lo caro que son los hospitales de Monterrey. Esos hospitales son Natividad, Valley Health, Community Hospital, CHOMP. Y tuve COVID al inicio de la pandemia en marzo del 2020. El plan de salud de mi sindicato pagó más de $500,000 por la estadía de 3 semanas en CHOMP, aproximadamente $25,000 por día. Debido a que tuve COVID, todas mis facturas fueron pagadas porque no tuve que pagar nada de mi bolsillo. Pero esa no es toda la historia. CHOMP todavía toma dinero de mi bolsillo porque los hospitales se les paga con el mismo bolsillo de dinero que mi sindicato negocia para mi salario y mi pensión. Si los hospitales como CHOMP cobran mucho, queda menos dinero para los aumentos. El plan de salud de mi sindicato cubre a los trabajadores de la industria hospitalaria como yo en todo el país. Muchos de nosotros nos contagiamos del COVID ya que trabajamos con el público. En promedio, nuestro plan sindical pagó $40,000 por caso de COVID en todo el país, incluyendo lugares como Boston y Nueva York. En Monterrey, el promedio fue de $173,000. Esto es 4 veces más. Todo esto sale de los bolsillos de los trabajadores como yo. Mi caso de COVID duró mucho tiempo. Tuve que dejar de trabajar e incluso estoy pensando en declararme en bancarrota porque todavía tengo una deuda con el hospital y tengo algunos meses de haber regresado a trabajar después de contagiarme de COVID. Está mal que los hospitales como CHOMP ganaran tanto dinero durante el COVID a costa de personas de clase trabajadora como yo. Gracias por escucharme y espero que puedan tomar las medidas necesarias para terminar con estos abusos.
Let me read that in English for you. Good afternoon, everyone. My name is Alicia Ortiz, and I live in Marina, California, in the Monterey County. I'm here because it is important to give my testimony about how expensive Monterey hospitals are. Those hospitals are Natividad, Salinas Valley Health, and the Community Hospital of the Monterey Peninsula. I had COVID at the beginning of the pandemic in March of 2020. My union's health plan paid over $500,000 for my 3-week stay at CHAM, about $25,000 per day. Because I had COVID, all my bills were paid for, as I did not have to pay anything from my pocket. But that's not the whole story. CHAM still takes money from my pocket because the hospitals get paid from the same bucket money that my union negotiates for my wages and my pension. It helps hospitals like CHAM charge a lot. There's less money left over for raises. My union's health plan covered hospitality workers like me across the country. A lot of us got COVID since we work with the public. On average, our union plan paid $40,000 per COVID cases across the country, including places like Boston and New York. In Monterey, the average was $173,000. That's 4 times higher. All of this comes out of the pocket of workers like me. My case of COVID case lasted a long time. I had to stop working, and I'm even thinking about declaring bankruptcy because I still owe a large sum of money to the hospital. And I went back to work a few months ago after getting COVID. It is wrong that hospitals like CHAM make so much money during COVID at the expense of working class people like me. Thank you for listening to me, and I hope that you can take the necessary steps to end these abuses. Thank you. Alicia Ortiz.
Thank you.
Thank you.
Moving back to the individuals in the room. If you'd like to make public comment at this time, please step to the podium. Seeing no one at the podium in the room, looking back virtually, reminding those joining us virtually to raise your hand, or if you're dialing in, press *5. Noting for the record that we have an estimated 70 people attending virtually. Seeing no hands at this time, that concludes public comment on this item.
Thank you, members of the public, for your helpful comments. Next up, we have a presentation on HCI's healthcare payment data program, which will be kind of managed by Deputy Director Pagani and presented by a variety of our colleagues and friends. I now turn the chair gavel really over to
Okay,
Dr.
I take
Galley,
it with,
and I note for the record that we are 10 minutes behind schedule at the time of this transfer. We will see where we end at the end of the afternoon.
no pressure. Thank you, Rick, for this. Vishal, is it you or is it Michael?
I'll do an introduction.
You'll do intro. Okay, to you, Vishal, and then we will open it up to the board. Great.
So for this agenda item, this is something we've mentioned at a previous board meeting that we wanted to provide an overview of the HPD program. So I have the pleasure of announcing or introducing Michael Valley and Jill Yegan. Michael is Chief Information Officer and Deputy Director for the Office of Information Services at HCI, where he oversees data analytics and technology. Since 2009, he has worked in a variety of policy and management roles within the department and with the Health and Human Services Agency, and has overseen the implementation of various data analytics and transparency programs during his tenure. Jill Yegan provides consulting services at the intersection of healthcare delivery, payment, and policy, aimed at improving the healthcare system on behalf of patients, providers, and purchasers. She is currently supporting HCI with implementation of the HPD and the Office of Healthcare Affordability. So I look forward to this presentation. Just want to emphasize that OCA and the Office of Information Services are closely coordinating because the HPD will be a powerful tool to analyze cost drivers. And so far, we're in close coordination on non-claims data, and look forward to as the HPD gets more sophisticated, to have it be a powerful tool to supplement the aggregate THCE data. And with that, Michael, take it away.
All right, thank you, Deputy Director Pagani. And I'm going to move the mic closer per the instruction from my director. And good afternoon, Chair and members and members of the public. Again, Michael Valley, Deputy Director for the Office of Information Services. I'm so happy to be joined by Dr. Yegian. Dr. Chris Krajcik was not able to be with us today due to a family emergency. He is HCI's Chief Analytics Officer and manages the office's healthcare analytics branch and all public reporting and analysis. But both Jill and Chris have been critical to our success, and on their behalf, we're happy to be providing an informational update on the implementation of HCI's healthcare payments database, California's all-payer claims database. As you know, the department has a very long history as a health data organization supporting informed decisions in the state. And if I may, I'd just like to take the opportunity to give a nod to Dr. David Carlisle for his leadership as OSHPD director for over 10 years. I know the success of this department with data analytics would not be what it is without you, and Director Landsberg and all of us are carrying on your legacy, and it's good to see you, Dr. C. Data has been a core part of the organization's mission from its founding through hospital financial data transparency beginning in the 1970s to hospital discharge data beginning in the 1980s, outcomes reports for cardiovascular procedures, and more. We have a number of new programs that our office is in the process of implementing that will add to the portfolio of data available to advance healthcare transparency. If you go to the next slide, please. These years of experience have well positioned us to take on the challenge of building the largest state all-payer claims database in the country, likely one of the largest databases of its kind in the healthcare payments database, or HPD. Though working with healthcare payers and with claims data is new for the department and our teams, we are excited to expand our data portfolio and serve in this role. We chose early on the name healthcare payments to recognize the prevalence of non-claims-based payments in managed care and value-based payment models in the state. Though we're starting with claims and encounter data, as all other states have, we have a longer-term vision to incorporate other payment data into the database as well. Go to the next slide, please. HCI has adopted a national standard for claims and encounter data, which includes common information used for billing, such as a patient's diagnosis, the procedure performed, and the amount paid for a claim. We are so fortunate to have a close relationship with the National Association of Health Data Organizations, which oversees healthcare administrative data standards. Adopting national standards improves data management, reduces administrative burden for data suppliers, and supports comparability across data set, and is a core contributor to HCI's success with data over these years. I'd like to take a moment to thank California's health plans and health insurers. They have been fantastic partners in this effort, supplying quality and timely data according to HCI's specifications and requirements. And I'd like to especially recognize Charles Bakke from the California Association of Health Plans and Stephanie Watkins from the Association of California Life and Health Insurance Companies, without whose partnership the progress made on the HPD to date would not be possible. I'd also like to thank the Department of Healthcare Services, who supplies all Medi-Cal data, fee-for-service, and from Medi-Cal managed care plans. Go to the next slide, please. HPD's program goals are enumerated in California Health and Safety Code and have been adopted by our Stakeholder Advisory Committee. I'll highlight the intent is for the HPD to advance transparency. The data should be used for the public good, protect patient privacy, and help achieve cost-effective, responsive, and equitable care. You go to the next slide, please. State policymakers, so many have been working on this for at least 2007 to establish an all-payer claims database in California. In 2008, HCI received the initial startup funding to begin studying and planning for how to build the database. And in 2020, the additional enabling authority to establish the database was granted. Since then, we've been heads down, building our team, working with data suppliers and other stakeholders, engineering the technology infrastructure to support the database, And I'm pleased to say that HPD released its first public report on June 27th, a few days prior to the July 1 date set for the database to be substantially complete, and Jill will be sharing more about that in a few minutes. We will continue to produce public reports on a regular basis. We're in the process of developing the data release program for access to non-public data by researchers and other qualified applicants. And we're working with all stakeholders on a long-term sustainable funding model for HPD. HPD's funding expires June 2025. Go to the next slide. I mentioned our stakeholder advisory committee. This is the policy level committee that advises HCI on program policy. Several HPD advisory committee members serve on the Healthcare Affordability Advisory Committee, and we thank them for their service to both offices and to HCI. HPD is also overseen by a data release committee. Their role is to review requests for access to non-public data and to advise HCI on matters of data use, data privacy, and data security. If you move to the next slide, please, on the screen, you'll see principles that HPD's public committees have adopted to guide the department on the use of HPD data. All of them are important, but I'll highlight item number 3. Use of the data should be feasible and credible with the available data and resources. We feel this is a key pillar of our work on this project, evaluating the appropriateness for the data to answer any particular research or policy question, given the quality and reliability of the available information, critical to maintaining the public's trust in the database and the information that comes from it. And so we do our very best to ensure our data and analyses can meet this high bar, and our public bodies that oversight our work have reinforced this principle. APCDs are powerful tools that can serve an important role in healthcare research and analysis, but they also have known and recognized limitations. We won't have claims for the entire California population. Some payers are exempt from reporting, and the uninsured and self-pay will not be included in the database. Data quality will continue to improve over time, and we work closely with health plans to get the best data possible from their systems. We do not have the non-claims payment data available yet. Jill will say more about that in a few minutes. There's a lag in reporting for claims run out, and also it's a very complex data system. Over 5 billion claims are loaded in the database now, over 17 billion total records, tens of millions of individuals, hundreds of thousands of plan products and providers, and that's from a 4-year historical period. This will continue to grow each year. It's certainly a big data integration effort for our organization. These are all areas that we are looking at, how to optimize the reliability and use of the HPD and learning lessons from other states as well. By March of 2024, HCI is required to submit a report to the California legislature that details the quality and completeness of the database, its limitations, and makes recommendations for improvement. This is something we're spending a lot of our time on right now. We look forward to submitting this report and continuing the conversation and welcome all feedback about HPD data quality. If you move to the next slide. In addition to advancing the goals of the HPD program, of course, the Office of Information Services, we feel, is well positioned to support the Office of Healthcare Affordability, as is the case in other states that have both a spending growth target program and an APCD. We fully expect that the data in the HPD can be useful and supplement and support total healthcare expenditure and other information that will be used by the affordability program. And my team, as Deputy Director Pagani says, has been and will be continuing to work very closely with the Office of Healthcare Affordability to prioritize areas where HPD can be the most helpful. With that, and we can go to the next slide, I'd like to turn it over to Jill to share our initial public reports and discuss the HPD public reporting priorities for 2023, which were adopted by the HPD Advisory Committee late last year and which continue to guide our work. And to note, the HPD Advisory Committee will be discussing the public reporting portfolio that my office will focus on for 2024 at their October 26th meeting later this year. With that, Jill.
Thank you, Mike. Good afternoon. It's great to be here with all of you. As Mike noted, I'll provide an overview and an update on HPD public reporting. Over time, we anticipate that HPD will develop into a very powerful database that's able to support a wide range of research and policy priorities. As Mike noted, HCI issued the very first public report on HPD data in June, and the public reporting portfolio will grow as HPD grows in its maturity, capabilities, and data over time. The early topics that are listed on this slide are ones that can be supported by the earlier stage of development and data, such as initial utilization statistics and chronic condition prevalence. The later topics will require some additional development time. The data will become more robust over time, both because there will be more data and because the data will improve through use. Features and enhancements will also be added over time, and the HCI analytic team will be able to build on past data products and visualizations to create new and more complex public reports. Next. So as Mike noted, HCI has come up with 3 public reporting priorities for the current year for HPD: the HPD snapshot, HPD measures, and pharmaceutical cost reporting. The milestone of releasing the HPD snapshot at the end of June was a very exciting one. The HPD snapshot provides a high-level overview of the data that's available in the HPD, including the volume of medical procedures and pharmacy claims, and I'll talk more about that in a minute. I do encourage you all to check out the HPD snapshot, which is very cool. That is a technical term, and it's just a really exciting milestone. HPD measures is in the coming soon category. That's expected to come out in the next month or so. And it will cover chronic conditions, demographics, and utilization dashboards. So moving from more of the count approach in the snapshot into the results approach through those dashboards. I'll talk a little bit more about that in a minute as well. And then the third is the pharmaceutical cost reporting. And this is really the starting point for reporting on cost. The snapshot and measures do not go into the payment data or the cost. And pharmaceuticals is a good starting place because near complete reporting can be accomplished through the claims data. HPD does not yet, as Mike noted, have non-claims data. And so we really want to look for a service category that is near complete with claims data alone. And so pharmaceutical costs represents that, and HCI is working towards a planned release in December. Next. So HPD snapshot, and the link is here in the footer, has 4 main views: the data overview, data availability, medical procedures, and drug prescriptions. And those are represented in the 4 snapshots on the right of the slide. The data overview presents counts of product types, of individuals, and total records, and then they can be filtered by payer type. So that would be commercial, Medi-Cal, Medicare. Claim type, that would be medical and pharmacy, and reporting year. So that's 2018, 19, 20, and 21 for all but Medicare fee-for-service data, which lags a bit because of the CMS reporting schedule. It also shows top product types by count of individuals. Data availability focuses on the count of enrollment and service records. Also includes member months and unique individuals, and that's shown by product type. And that is also filterable by claim type, payer type, and reporting year. Medical procedures actually returns the top 25 procedures and services by record count. And that result returns as well the procedure category and the type of setting being outpatient, inpatient, etc. That can also be filtered by type of setting, by payer type and reporting year. And then drug prescriptions returns the top 25 prescriptions filled by record count. And when that result returns, it includes the drug name and drug class. And filters are available for drug class, drug type, meaning generic and brand, payer type, and reporting year. And before I move on, I just want to note that the public reporting information that's available surrounding the HPD snapshot and the initial milestone of reaching public reporting is really impressive and worth checking out. I want to give a shout out to the team. It was a tremendous amount of hard work by Mike and his whole team. There's a webpage for public reporting that includes an FAQ. There is a link to the state's open data portal. I'm sure many of you have used that. The open data portal is amazing. The underlying data can be downloaded. There are technical notes. There's really a wealth of information so that users can really understand and interpret what they're seeing. Because even at the level of the counts, the data is enormous and complex. Next. So the HPD measures is the public report that will be out in the next month or so. This one focuses in three main areas: chronic conditions, demographics, and utilization measures. And like the snapshot, there are 4 views displayed here on the right as well. There's a measure map so that you can see the geographic areas within the state. Measure trending is the next, so you can see the change in the measures over time. The statewide comparison essentially provides the benchmark in the display for the state as a whole for easy reference point, and the measure table returns the results for whatever filters and grouping measures you have in place. There are 23 different measure categories across the 3 categories. So there are different selections in chronic conditions, in demographics, and in utilization, such as ER rate, inpatient surgical rate, chronic disease prevalence for anxiety or stroke. And then in addition to those measure categories, there are filters for age band, for county, for covered California region, payer type, sex, and reporting year. So when you sort of compile all that, it's a very powerful set of tools that's quite simple, but also very meets a whole array of questions and needs. Next. So where do we go from here? So HPD will be continuing to produce public analytic reports and refine potential use cases. HCI has a rich history and existing portfolio of data visualizations, and the HPD public reports will build that out and contribute to it going forward. There is, as Mike noted, an array of opportunities to engage with HPD. HPD is very interested in input on existing public reports, input on future public reporting priorities. There are opportunities to join the advisory committee meetings or the data release committee meetings and to provide feedback on any of the products that are out. And then in addition, I'll just say a word about non-claims payment data. It's a very exciting milestone coming up. As all of you know, California has a tremendous amount of non-claims payment in our market, and so that is an essential addition to the claims and encounter data that is in HPD currently. And so what that is, that work is underway now. The first conversation with the advisory committee happened in January. We'll have a follow-up conversation in October alongside the public reporting priorities conversation that is also happening at that meeting. The work is underway to develop the framework for what that data collection will look like, and it's anticipated that regulations will be developed in 24, and the first data will be collected in 2025. So with that, I will turn it back over to Mike.
Thanks, Jill. And I just want to, again, happy to introduce everyone to Jill and to myself and hopefully to Chris in the future. There's so many more folks behind the scenes that should also be recognized for their contribution to HKI's data and analytics work and the HPD. And I just wanted to recognize them as well. And with that, I'll say thank you and turn it back to the chair.
Thank you, Jill, Michael. Vishal, open it up to the board for questions, comments. Ian first.
Yeah, as a layperson, I hope I use the technical term right. This is cool. So thank you for this great work. Yeah, in the last agenda item, you heard again, a conversation we've been having around the non-claims data, and again, as a layperson, Don spoke to the quality of data he's getting from Kaiser. Rick spoke about it too from the ERISA side. We've also been getting that for years, mapping the cost to the encounter data from. So what is, I'm sure it's not as simple as just taking the programs that CalPERS has built to do that mapping and just plugging it into the HPD, but what prevents you from just adopting one of those other examples and getting that those costs attributed? Jill.
So we're in conversation with a whole range of partners about how they approach non-claims data, and that includes CalPERS and Cover California and other states as well. And so I think there are two different issues. One is about the data collection itself, and the other is about what one does with it in terms of connecting the dots behind the scenes, right? Attributing, so I think what you're referring to would be, for example, having monthly capitation data and then connecting it to some form of encounter data records to try to create meaning from that. Is that right?
Yeah, that's exactly what the data warehouse I'm associated with has been doing for years, and to the point that we can do the risk adjustment and repricing to Medicare fee-for-service rates and those sorts of analyses. And it just surprises me that it's such a long time horizon to make this, to do that here. And that's just from my ignorance. I understand there are legitimate reasons for that.
No ignorance involved at all. It was a long and challenging conversation a number of years ago about whether the non-claims data would be sort of phase 1 or phase 2. And given the scale and complexity of this undertaking, the decision was made to make it phase 1.
And just to add to that, our stakeholder advisory committee actually had a motion vote on the recommendation to start with claims and encounters. So I think robust discussion, certainly eagerness to get the data, but an acknowledgement that program should start small and grow over time.
Well, Michael, just thank you very much for your kind words right at the beginning. I just wanted to say California is where we are today because of the richness of our data programs, and I'm looking forward to the continuing cultivation of those programs. I know the all-payer claims database has been a desire and dream of many people for a long time in California. I think that's finally being addressed. I did want to call out a special component and say thank you very much for also prioritizing disparities data and analyses here. I think it's going to be very important for California's data future as well. So again, thank you very much.
Elizabeth.
Thank you. And I don't know quite who to address this to, but I know many states have had APCDs for decades, and they are important tools, but they haven't always enabled affordability. And just, I know you're considering the design to really how do we get at affordability from a consumer perspective? I guess, maybe this is for future meetings, but how do we accelerate really focusing on that? I understand all the need to talk about infrastructure, but literally in the last 6 months, a lot of employers have had double-digit price increases. So, I'm not taking away at all from the importance of the informational work, but just feeling some urgency and wanting to make sure we're tracking, we're building the tools that will truly enable affordability for consumers. So maybe that's just a general concern, but also, thinking about leveraging experience in, with other data sets, other states, to really get at that out of pocket impact. Just how do we just make sure that that's front and center?
Director Landsberg, I'm also happy to take a crack at it.
Go ahead.
From my other hat, I think one of the points of the presentation today and the history of the all payer claims database in California is its intersection with this conversation, this board, and the work of OCA. And I think one of the reasons why it's important to talk about this early in our sort of formation is that the partnership between Michael and Vishal through Director Landsberg's sort of guidance and support is hopefully we get to kind of push where this database goes and how it begins to address some of our critical needs. I think that it's early. You heard that in the conversation. We've all, one other thing that came up is funding for this moving forward. There's a lot of pieces that still have to be secured, but I think there's an opportunity for us as an entity to raise, just as we have in some other areas, where this should go and how it addresses the point you made around affordability, but other aspects. So hopefully the invitation to have the presentation is one to say, let's iterate and figure that out exactly. And I think our feedback and push is going to be critical to the team to keep thinking through that.
And I just want to add, I appreciate the comment, and please know that we continue to ground ourselves in the affordability of consumers, and it's frustrating, right, to hear the heartbreaking stories that we hear in public comment, to see the rate increases, and know as Mike says, we have to put our head down and do the work. So yes, there's a great collaboration going on between Vishal and Mike. We when I talk about OCA and I talk about how we're trying to slow the spending growth, sometimes it's frustrating that we can't do more, and yet we're very aware of the need to really have that be our North Star of consumer affordability. We've always said that OCA and HPD will work hand in hand with OCA having the aggregate data, and as we identify cost drivers, that we'll be able to do a deeper dive analysis with HPD. So yes, we wanted you all to have a sense of the tool. I know some of you are more familiar with it than others, and we do very much plan to roll up our sleeves and use it as an important tool as we move forward.
Well, and craft it as that tool. And I think that's where the participation of this board in saying, hey, can it do this? The answer is probably today no, but how do we prioritize that? Richard.
No, I really appreciate the presentation as someone who actually was involved in some of those, we say deliberations and discussions. In fact, I was chair of the budget subcommittee for the state Senate on Health and Human Services that put in the $60 million for support of the governor in that budget back in 2018-19. I think the vision was that in order for us to get at affordability, we needed data, right? You don't kind of throw darts at the wall. I mean, we have to so this was a vital piece of information. I remember engaging in conversations with health services researchers and people in other states about how they've done it and trying to figure out how can we move California forward, and conversations with, the Brown administration, and now, then of course now we're some administration. So it is a vital part of that story. I don't think we would have HCI right now, if we wouldn't have this body right now if that work wasn't done before. So I certainly understand the impatience as we're all watching healthcare spending grow, but I think also this is a vital part of this. And again, I want to thank you so much for doing the groundwork, and there's obviously a lot more work to go, but it's good to see the results of this initial results of the investment that at least I played a small part in trying to get in back in that previous budget, and finally seeing it come to reality with this year with the dashboards and so forth. So thank you.
As a data geek, I am grateful for the HPD and the work that you all have put into it. Jill, I wonder what I might be able to extort from you for not telling your children that you characterize the data visualization as really cool. But I do wonder, given Elizabeth's comment, does the HPD have allowed amounts in it at this point?
It does. It does.
It does. Okay. So, you know, Elizabeth, your comment, I mean, it seems like it will be a powerful tool to try to figure out, you know, we know that premiums are going up at 10, 11, 12% this year, more. You know, what part of that is utilization? What part of that is price? Where is the price? You know, we've heard many moving pleas about Monterey. The HPD will be able to make transparent what prices are in Monterey, which there are other, you know, I mean, Don's got that now, your members have that now, but to have that out in public will be powerful.
Yeah, I actually assembled an APCD about 20 years ago, and there is huge utility, but it really truly is about asking the right questions and the governance and the rules of sort of use. So I completely concur. I'm just eager to sort of be able to fully leverage the investment.
Well, and I'll just say, I think this board, we want to know what those ideas are and share them publicly, even if it challenges, you know, the team earlier than expected. I think it's all meant to be iterative and push towards ultimately a useful tool. Because the data for data's sake is interesting to some, but not necessarily as impactful as I think it could be on in this mission. Other comments from the board? I'll just add, I appreciate the hard work over the last few years as I've been a part of it, working with then Senator, but Dr. Pan on getting this funding, figuring out what we're going to agree to get off the ground early and how it's going to evolve. I think really in the underbelly of your comments is we've started, and that start is worth celebrating, but you got your head down and you're continuing to have it evolve into the tool that Elizabeth and others want to see it become, so that we can do, whether it's disparities focused work, the affordability, which is connected, all of this work. I think it's an exciting place. And the fact that some states had this 20 years ago is not a shining moment for California, but the fact that we have one now, I think is really important. Congratulations to the team to getting it off the ground. And,
thank you, Dr. Galley.
Yeah.
And Dr. Galley, if I could, I just want to appreciate, again, Dr. Carlisle raising up the issue of disparities. And I've been pushing the team hard on that of when are we going to have the demographic data to really look at health disparities. I will say it's somewhat frustrating that we don't have as better demographic data than we do. And so we're pushing our plan partners and others, and those conversations are happening. But obviously we only have what the data shows us, and I'm pretty discouraged that we don't have more complete race, ethnicity, language, and some other areas of data.
But this blind spot is how we get started.
Absolutely.
I mean,
we need to know what we don't have to push.
Yeah, I was going to try to not say anything, but Dr. Carlisle brought it up, and now you brought it up. So, you know, we're collecting the demographic information that we need to do that analysis, and now have enough to have adequate sample, and are starting to run the analysis at CalPERS. Cover California, as Mark knows, doing the same thing, and DHCS is doing the same thing. And I think there's a good amount of interest in the private side purchasers in California, at least some of them. So, you know, I do think, I mean, to the extent that the three large purchasers in California can be helpful in facilitating that, one, great. But two, we're doing this real time and with adequate but not the desired sample, and having benchmarks and understanding sort of what's going on in California at large is hugely important. So to the extent that there is an ability to kind of push that, that would be a very positive thing for all of us, I think.
Okay. Thank you again for the presentation. Let's move to public comment, both on this item, and then as this is our last item, I don't know, is it fair to do general public comment altogether, or should we segment them together? Okay, so we will open it up, this item, and general public comment.
Beth Capel on behalf of Health Access. We are thrilled to see the HPD live. We have been advocating for one for at least 2 decades. And so thank goodness it's finally here. We appreciate the progress that's being made. We do think that it's important to include, since 20 years ago, rates were confidential. That's no longer true. Negotiated rates are public for both hospitals and health plans. And so that should be part of what is available, and it should be at the entity level. And when we talk about confidentiality, we're talking about the patient's confidential information, not the hospital or the health plan. With respect to equity, we need to think about not only race, ethnicity, language, sexual orientation, and gender identity, but also income when we're thinking about the commercial population. A lot of the work that has been done has been in the Medicaid space, where by definition, you're dealing largely with a low-income population. But with a commercial population, income also becomes an important factor in terms of analyzing for equity. And so we'll look forward to this continuing to develop, and in partnership with the work here at OCA to set targets and move to entity level targets, which I know is down the road, but it's on the list. So thank you.
Thank you.
All right, looking virtually, we have a hand raised. Stephen, please go ahead.
Hello again, folks. It's Steve McDougall with the California Federation of Teachers. Something that's happening in Monterey County is twofold. One, after doing some research ourselves, we've discovered that our urgent care centers that are owned by local hospital providers refuse to see patients after 2 or 3 o'clock in the afternoon and turn folks away at that point. So then they have to decide, is this emergent or not? If they end up in the emergency room and it's coded incorrectly, or if the network rejects the claim as being emergency, guess what happens? Financial ruin. Now, there's telehealth. When folks access their telehealth option provided in their networks, telehealth almost always errs on the side of caution and sends them to the emergency room, even when perhaps they shouldn't go there. And then everyone pays in the plan. It is a rigged game in Monterey County, and something needs to be done. I don't even know. Attorney General, are you listening? I know this isn't your gig, but something's got to be done. We need help. We needed help 10 years ago. We're way beyond the scope of the work of what you all are doing. It's that bad here, but we need help. It's long past sustainable. Thank you for listening.
Thank you. Other virtual comments?
No other virtual at the time. Reminding virtual attendees to raise your hand. If you're dialing in, press *5, alternating to those back in the room.
Both comments on the HPD are general comments on the meeting. Yes, please.
And please make sure the microphone light is on green there.
Hi, I've called in a few times virtually, and I've been to one of the workshops last week. I enjoyed the discussion on transaction regulations. I'm Harvey McKeown. I'm from the NorCal Carpenters Union. I'd like to give just some general perspective from our status as a purchaser, touching on some of the themes discussed today. So really, our main healthcare provider, Kaiser, is pursuing 15 to 24% rate renewals for employee groups, while publicly reporting year-on-year expense increases of only 4%. For retirees, the rates proposed are even higher. In our own notice, we've seen charges on a per member per month basis increase 17%, despite a decrease on the charge categories utilization metric. So one of the questions we're beginning to have amongst the many about this organization's transparency is who is pushing business units to assign higher charges? So far, we've been unable to get answers. Begging a question, is this coming from the C-suite? Kaiser had a leadership change in 2019, new CEO. And at the same time as Kaiser now begins to propose these extortionate rate increases to California consumers, Kaiser's current leadership is trying to expand its corporate empire. We've heard about the Geisinger acquisition today. And to the point earlier today about whether these transactions are beneficial or not for consumers, I'd like to point out that the evidence shows that often executives make claims that are not backed up with any evidence. And really, it's a self-justification measure to try to expand the business, raise corporate pay. Greg Adams makes around 15 million a year.
10 seconds.
Is the CEO of a nonprofit. So I would ask you, to expand the scope, look at executive pay, realize I'm running out of time. But yes, thank you for taking the comments and thank you for the work of this body.
Thank you. Any more virtual?
Seeing no virtual hands at this time, noting that our virtual attendees are still at an estimated 60 individuals, no hands.
I feel like the going once, going twice, gone in the room. Okay, seeing nothing else. Okay, we're at the end of our agenda. Thank you. Again, apologies for being here late. Appreciate, Rick, you filling in. And I'm just going to take one 30-second chair prerogative just to congratulate you, Dr. Carlisle, and Drew's 4-year medical school achievement. I know you had the first white coat ceremony for your class. Just so people know, I think the 157th, is that the right? 4-year medical school?
Our official number is 157 in the AAMC lexicon, number of medical schools in the country.
Yeah, so big achievement. And as we talk about primary care spend and primary care access and disparities in data, to have one of our one of the 4 historically Black medical schools here in California, in Southern California, led by you and your team, Dr. Deborah Prothro-Stith as well. Just really appreciate how all of this work moves together, and just want to take a moment to congratulate you and your team for that amazing achievement, and the students that are going to benefit from the opportunity to train there, and the patients that will get the care they need because of it. So thank you. Okay, with that, we're adjourned. Thanks so much.